What's up, guys? This is going to be the Hematology Oncology section for Pance studying. So we'll go ahead and get started. So first, the rouleau formation. So the rouleau formation is basically stuck together red blood cells, and it looks like a stack of coins. They'll have an elevated ESR because they're heavier, so they sink to the bottom when you're looking at the sediment tube. So it's basically stacked red blood cells that float to the bottom of the sediment tube. They'll have an elevated ESR, like we said, and also multiple myeloma is the most common cause of this, and also chronic infections. Autoagglutination is a little bit different. So autoagglutination is clumping also of red blood cells, but this is due to autoantibodies, such as especially cold agglutinins, which is an autoimmune hemolytic anemia, and that could be from things like Mycoplasma pneumoniae and Epstein-Barr virus. Also antibody-antigen reactions if they're not typed and crossed as well. So basically in cold temperatures, it results in clumping of the red blood cells due to antibodies, which gets picked up by the spleen and then destroyed. So the spleen will clear out any of these clumping red blood cells or the stacked red blood cells in the rouleau formation. And so I'll put a picture up so we can really discriminate between these two to see which one's more of a clump and which one's more of a stack of coins, like in multiple myeloma. So we'll go to Howell-Jolly bodies. Howell-Jolly bodies are basically a problem with basophils inside the red blood cell, which usually gets cleared out by the spleen. So it's a marker of decreased splenic function if we do see the Howell-Jolly bodies with that intact basophils inside. So decrease in splenic function is going to be indicative of Howell-Jolly bodies in the red blood cells. So next we'll go into some of the hemolytic cells. So there's bite cells, which are bite-like deformities due to the phagocyte removal of the cell itself due to the denatured hemoglobin. This will be common in thalassemia as well as G6PD deficiency. So remember G6PD deficiency with those bite cells and Heinz bodies. And also it's important to know schistocytes. These are just fragmented red blood cells. They're common in hemolytic anemias, microangiopathic disease, also glomerulonephritis when they're getting destroyed going through the small vessels of the kidneys, and any other thing that would damage the red blood cells itself. And then I briefly wanted to cover the ABO and blood donations, so which blood types can give to which and which can receive what. So first we'll go over A. Blood type A can give to blood type A and also AB, and it can receive from A and O. If they're blood type B, they can give to A, B, as well as B, and they can receive from B and O. And AB blood type can only give to AB, but they can receive from A, B, AB, and O. And blood type O can only receive from O, but it can give to all. So that's the universal donor, the O blood type. And if they're Rh negative, they can give to Rh negative and Rh positive, but if they're Rh positive, they can only give to Rh positive. So we'll go into basophilic stippling. So there's a couple important things to know for basophilic stippling. These are just blue granules in a ring around the red blood cell. So coarse blue granules in the red blood cell. This is due to residual RNA in the red blood cell. It looks similar to reticulocytes, but basophilic stippling is evenly distributed through the red blood cell. It's most commonly acquired, especially in sideroblastic anemia, as well as heavy metal poisoning like lead, plumbism, and arsenic poisoning. Also, it could be in TTP as well. Most importantly, sideroblastic anemia, also some thalassemias, and also lead poisoning. So basically the ringed red blood cell with granules from iron in the mitochondria. So it's a problem in the porphyrin pathway, which leads to excess of what's eventually needed for synthesis, so it accumulates around the red blood cell, and here it says it's evenly distributed through the red blood cell itself. Echinocytes are also called Burr cells, and this is common in uremia, so Burr and uremia both have a U, so that's how I remember Burr cells in uremia. And acanthocytes, these are spur cells, which look very similar. And then target cells, which are caudocytes and spherocytes. So target cells are hypochromic red blood cells with a round area of central pigment and target-shaped nature. They're seen if there's excess cell membranes in relation to the hemoglobin content. So it makes sense why there's so there's also target cells. Target cells are common in hemoglobinopathies like sickle cell, thalassemia, also severe iron deficiency anemia. And these are basically hypochromic red blood cells with a round area of central pigment and a target-shaped middle. It's seen if there's excess cell membrane in relation to the hemoglobin content itself. So it makes sense why this is seen in thalassemias, because in thalassemias we have a loss of the globin chains. So there's that excess cell membrane, and it makes it look like a target cell. We also have spherocytes. So this is typically with hereditary spherocytosis. So they're hyperchromic because instead of the typical disc shape of the red blood cell, they're more just in a circle, in a sphere. So it's going to appear very hyperchromic. And it's also common in warm autoimmune hemolytic anemia. So we said cold autoimmune hemolytic anemia would have autoagglutination, whereas warm autoimmune hemolytic anemia will have spherocytes potentially. And just to go over a few key concepts in hematology in general. So a left shift versus a right shift. So a left shift is young reticulocytes. They're large and macrocytic. It's also called a bandemia. These are cells that get smaller as they properly mature. So in the maturation process, the cells go from larger to smaller and then are released into the serum. So this is a response to or an increase in need perceived by the body due to chronic infection or such as rheumatoid arthritis or SLE, or more commonly infections is when you see a left shift or bandemia. A right shift is due to a decrease in splenic clearing of the old cells. So they're shifted to the right and they're smaller and older because they've been there for a while as well. Anisocytosis is the abnormal size, so that's the MCV, and poikilocytosis is abnormal shape. So that'll be like in sickle cell, hereditary spherocytosis as well, and damaging, such as schistocytes through the glomerulus as well. So it's important to mention hypersegmented neutrophils as well. This is common in B12 and folate deficiencies, and this is when the neutrophils have over 5 lobes. I'll also mention Auer rods here. Auer rods are in AML and Reed-Sternberg cells as well. Reed-Sternberg cells are in Hodgkin's lymphoma. So Hodgkin's lymphoma, Reed-Sternberg cells, and Auer rods in AML. So first we'll go into an approach to anemia. First we want to look at the MCV, which is typically from 80 to 100 centiliters. So anemia with a low reticulocyte count can be separated via MCV, mean corpuscular volume, into a normocytic, 80 to 100, a microcytic, under 80, or a macrocytic over 100. And what we want to do is take a look at the MCV and determine what's in the differential. So first we want to approach it by looking at, is it high reticulocytes or low reticulocytes? So if they do have high reticulocytes or reticulocytosis, this signifies an increase in blood loss or an increase in red blood cell destruction. So reticulocytes are those baby red blood cells, and they're going to be pumped out there if we're constantly losing blood. So such as in red blood cell destruction, like a hemolysis or overt blood loss. So if we have blood loss, that could be due to occult losses, like fecal occult blood loss or tissue losses. And in red blood cell destruction, we want to look to see if it's intrinsic or extrinsic hemolytic anemia. So intrinsic would be a hereditary hemolytic anemia, and that would include G6PD, sickle cell, as well as thalassemia, or hereditary spherocytosis. If it's an extrinsic or acquired hemolytic anemia, which is also increase in red blood cell destruction, this would be an autoimmune hemolytic anemia, could be cold or warm agglutinin, also meds like SLE, rheumatoid arthritis, or Hodgkin's lymphoma, or CLL, chronic lymphocytic leukemia. Hypersplenism as well, DIC, disseminated intravascular coagulation, TTP, and HUS as well. Also paroxysmal nocturnal hematuria are all examples of extrinsic or acquired hemolytic anemia. If you go to the other side for the overall approach to anemia and look to see the reticulocytes and they're low, this signifies a failure or a decrease in red blood cell production. So again, reticulocytes are those baby red blood cells. So in this side of the algorithm, we're having a low increase of reticulocytes. So then we want to look at the MCV. So what's going on? So if we have an under 80 MCV, this is a microcytic anemia. And a microcytic anemia, the differential is most commonly iron deficiency anemia, also lead, thalassemia, and early anemia of chronic disease. And how we can remember these are TICS, T-I-C-S. So T, thalassemia, I, iron deficiency anemia, C, chronic anemia of chronic disease early on, and S, sideroblastic anemia. So those will be the microcytic anemias, which are under 80 MCV. If we have 80 to 100 MCV, which is normal, this is a normocytic anemia, could be anemia of chronic disease, also renal or mixed anemia, endocrine dilutional, importantly, or an early iron deficiency anemia as well. For a macrocytic anemia, there's a few options: B12 deficiency, folate deficiency, liver disease, alcohol, as well as hypothyroidism could all lead to a macrocytic anemia, which is an over 100 MCV. Also, it's important to know a few different white blood cell lines. So neutrophils are the most common cell of the white blood cells. This is about 60%. They have more lobes, which means they're older. So the more lobes they have, the older they are. And these are also called polymorphonuclear white blood cells, neutrophils. So lymphocytes are about 20 to 40%, and lymphocytes are not granulated, and lymphocytes are typically elevated in viral infections. Monocytes are about 2 to 8%. Monocytes are granular and they're very large circular cells. Eosinophils are about 1 to 4%. And these are increased in parasitic infections as well as allergies. And they're also granular. And for basophils, this is only about 1%. They're more rare and they have a deep blue granule, as we saw in that basophilic stippling, in which they had ringed blue dots around the red blood cells. So for microcytic anemias overall, there's a few different etiologies that we should know. The three most common are iron deficiency, alpha and beta thalassemia, as well as early anemia of chronic disease. Lead poisoning is also in the differential. And some of these etiologies are a decrease in iron availability, which is severe iron deficiency, also anemia of chronic disease and copper disease. Decrease in heme production, so lead poisoning, sideroblastic anemia, are a decrease in heme production. Also decrease in globin production. So these are of course the thalassemias and hemoglobinopathies like sickle cell, hemoglobin, sickle cell. They all present with hypochromic microcytic anemia. Iron deficiency anemia overall is the most common cause of anemia worldwide. There's two different etiologies. Chronic blood loss is one. This is the most common cause in the US. This could be due to excessive menstruation, occult GI, blood loss, like colon cancer. Also, parasitic hookworms are the most common cause of blood-related IDA in resource-poor countries. Decreased absorption through the diet, most commonly caused in the world, and celiac, bariatric surgery, and H. pylori could be causes of this decreased absorption. Some of the risk factors for iron deficiency anemia are an increased metabolic requirement of iron itself, like in children, also in pregnancy and lactating women, in cow milk ingestion in younger children. So infants fed cow milk younger than 1 year old, and toddlers fed large amounts of cow's milk as well, could lead to that iron deficiency anemia. The pathophys overall is decreased red blood cell production due to a lack of iron and decreased iron stores, decreased ferritin. Normally iron is stored in ferritin, primarily in the bone marrow, liver, and spleen. Clinical manifestations, there's many to know for iron deficiency anemia. So they'll have those classic symptoms of anemia like fatigue, weakness, exercise intolerance, and dyspnea. And for CNS, they'll have a poor concentration, apathy, irritability, poor school performance, also some cognitive disturbances overall, and importantly, restless leg syndrome also patients can have from iron deficiency anemia. So that's restless leg syndrome. They can also have pagophagia, which is a craving for ice, specifically ice, and also pica, appetite for non-food substances like clay or starches. On physical exam, we'll see koilonychia, which is spooning of the nails, angular cheilitis, which is inflammation of one or both of the corners of the mouth. They'll be tachycardic in an effort to get more oxygen to their body, and glossitis, which is a atrophic smooth tongue, and also signs of anemia, further signs of anemia like pallor. So for diagnosis, we'll see a microcytic, hypochromic, so lacking color, anemia, which is classic. Maybe normocytic or normochromic early on, however. They'll have an increased red cell distribution width, which is the range between the large cells, which are the baby reticulocytes, and the small red blood cells, which are more mature. So lots of small red blood cells because they stay in the bone marrow until the last minute. So they're waiting in the bone marrow before they can get released into the cells for that iron that they need to be a functional red blood cell, but they never get it because it's iron deficiency anemia. So that's why we have microcytic cells in iron deficiency anemia, and why we have a large red cell distribution width as well, because there's a range between those types of cells. Again, decreased reticulocytes, and may have thrombocytosis and poikilocytosis as well. So we'll see a decreased ferritin, which is the stored iron, and that's pathognomonic. That's how we can really determine that this is iron deficiency anemia. Also an increased TIBC, and an increased transferrin, a decreased transferrin saturation, under 20 to 15%, and decreased serum iron overall. So that's decreased iron, decreased ferritin, decreased transferrin saturation, increased total iron binding capacity, the TIBC, and also an increased transferrin itself. So how else can we have a decreased TIBC? It could be decreasing the hemolytic anemia, also a thalassemia and cirrhosis, and in hemochromatosis it'll also be decreased. We don't need any more iron in that. And also in chronic disease it's decreased as the body tries to sequester away all the extra iron, as there's mechanisms that say it's more common to have a progressive bacterial infection or other pathology with increased iron in the serum. So we'll have a decreased TIBC in that case as well. And for bone marrow, absence of iron stores is the definitive diagnosis technically, but that's rarely performed. For management of iron deficiency anemia, oral iron replacement results in an increased reticulocyte count within 5 to 10 days, and a correction of the anemia in 6 to 8 weeks, and repletion of the iron stores in 1 to 3 months. For preparation, we want to do oral, that's ferrous sulfate, and also iron-containing formulas in bottle feed infants. Iron-enriched foods and red meat. You could also do parenteral iron as well. Constipation is a big side effect to know, and also liver eating. Animal liver is a good source of iron. So we want to take iron replacement with vitamin C, ascorbic acid, or with water or orange juice on an empty stomach. Iron should also be given within 2 hours before or 4 hours after ingestion of antacids, as reducing the acid impairs the absorption. So if we have decreased acid also as in a PPI, this will also decrease the absorption. So that's why we're taking the orange juice to increase the acidity of the stomach. And like we said, constipation is an adverse effect, also nausea and vomiting, other GI effects, dark stool, and you want to gradually increase the dose to reduce the GI effects. In severe life-threatening anemia, red blood cell transfusion should be done, such as in like a myocardial infarction. For lead poisoning anemia, such as plumbism, the pathophysiology is lead that poisons enzymes causing cell death. It shortens the lifespan of the red blood cells, and it inhibits multiple enzymes needed for heme synthesis, causing an acquired sideroblastic anemia. Risk factors are most common in children, especially under 6, due to increased permeability of the blood-brain barrier, as well as iron deficiency. Sources are typically ingestion or inhalation of environmental lead, like in paint chips or lead dust, as the primary source of childhood lead poisoning in the US. So lead was used in household paints prior to the 1970s as well. Lead in gasoline and industrialization of the use of lead. Clinical manifestations of lead poisoning, plumbism, may be asymptomatic. They also have importantly neurologic symptoms like ataxia, fatigue, learning disabilities, difficulty concentrating, developmental delays, hearing loss, peripheral neuropathy, wrist or foot drop. They could also have encephalopathy, and especially GI concerns as well, like lead colic, intermittent abdominal pain, loss of appetite, vomiting, constipation. And they can also have anemia, renal disease, as well as Burton's lines. So it's important to know Burton's lines. This is different from the lead lines, however, on radiograph. But Burton's lines are thin, blue-black lines at the base of the gums near the teeth. seen primarily in adults, however, with plumbism. So that's Burton's lines for plumbism. So for diagnosis, you want to do serum lead levels over 10 micrograms. On venous sampling is the most accurate. You could do a capillary finger stick as well initially. And on peripheral smear, it's important to know microcytic hypochromic anemia with basophilic stippling, dots of denatured RNA seen in the red blood cells, and ringed sideroblasts in the bone marrow. You'll have a decreased TIBC and a normal or increased serum iron. Increased erythrocyte protoporphyrin. This is elevations can be seen in both iron deficiency and lead poisoning, but they tend to be worse with lead poisoning. And of course on radiographs, the lead lines, classically. So classically, the lead lines on radiograph are linear hyperdensities at the metaphyseal plates in children. The management, of course, removal of the source of lead is the most important component to treatment. Removal of the source of the lead. So we need to know if it's mild, moderate, or severe. What do we do? So if it's mild, which is 44 micrograms or lower, you can do outpatient follow-up and lifestyle modifications. If it's moderate, about 45 to 70, you want to do Susamir first line as an inpatient. This is an oral chelator. So Susamir first line as an oral inpatient with moderate lead from 45 to 70 inpatiently. And that's oral chelation. Calcium disulfide edenate, EDTA, is an oral therapy if not tolerated, and D-penicillamine third line. So overall for moderate lead poisoning, Susamir is first line. You can also do EDTA, and then last line will be D-penicillamine. All of them are chelators and they need to be done inpatient. For severe, 70 or higher, if that's without encephalopathy, you can do Susamir plus EDTA, or if they do have encephalopathy, you can do EDTA with dimer-caprol, IM. So next we'll go into a thalassemia overview. So thalassemia is a decreased production of the globin chains. And this is a distribution of thalassemia which follows Plasmodium falciparum. It's thought to be a genetic benefit versus malaria. Normally after 6 months of age, adult hemoglobin is the predominant hemoglobin produced. So adult hemoglobin A, and there's hemoglobin A2 and hemoglobin F. So hemoglobin A is the adult, and that's 2 alphas and 2 betas, and that's 95%. If you have hemoglobin A2, that's 2 alphas and 2 deltas, and this is under 3%. And hemoglobin fetal is 2 alphas and 2 gammas, and there's only trace amounts of this. And this is all considered after 6 months of age. So that's how the profile is after 6 months of age. Mostly 2 alphas and 2 betas. So you want to think thalassemia if microcytic anemia with a normal or an increased serum iron and no response to actual iron treatment. So you always want to try to treat that iron deficiency anemia first, and if they're not, then you want to suspect the thalassemia. So next we'll go into alpha thalassemia. Alpha thalassemia is a decreased alpha globin chain production. There's 4 genes that determine it. So depending on how many of these 4 genes that they have will depend on the severity of the alpha thalassemia. So most commonly are Southeast Asians, Africans, and Mediterranean patients. And if they have a silent carrier state, only 1 out of the 4 alleles is abnormal. And clinically, they'll be asymptomatic for these patients. So we're really only going to see 2 of these patients, the patients with the minor trait and the intermediate trait, which are 2 out of the 4 alleles abnormal and 3 out of the 4 alleles respectively for the intermediate. In 4 out of the 4 alleles that are abnormal, this will be a hydrops fetalis, and this is incompatible with life, so we won't really see this patient. It's associated with a stillbirth or a death shortly after birth, and this is what the hemoglobin Barts is. These are the gamma tetramers, so 4. So these patients are never getting born. It's incompatible with life for hydrops fetalis with the 4 out of 4 genetic mutation. So again, to go through them, a silent carrier will be 1 out of 4, an alpha thalassemia minor trait will be 2 out of 4, and they'll have a mild microcytic anemia. If they have alpha thalassemia intermedia, this will be 3 out of 4, and this presents similar to beta thalassemia major, however. And 4 out of 4 again the incompatibility with life, and that's a hydrops fatalis, and that's also known as hemoglobin Barts. So that's gamma tetrameres. Thalassemia should be suspected in patients with a microcytic hypochromic anemia, a normal or increased serum iron, and a normal or increased ferritin. Hemoglobin electrophoresis in alpha thalassemia. 1 and 2 gene deletion is normal hemoglobin ratios in adults, distinguishes alpha from beta. If they do have a 3 gene deletion, it's the presence of hemoglobin H, a beta chain tetramer, which leads to Heinz bodies. And if they have a 4 gene deletion, this is the presence of the hemoglobin Barts. So that's Bart gamma tetramer. So hemoglobin H disease, alpha thalassemia intermedia. So this is a more serious one, again, similarly to beta thalassemia major. And this is the 3 out of 4 gene abnormalities. It's a type of alpha thalassemia characterized by decreased alpha globin chain production. The pathophys, again, 3 out of the 4 genes are deleted, causing a decrease in the alpha chain production. Excess beta chains from insoluble beta chain tetrameres, Heinz bodies, with no oxygen carrying capacity in the red blood cells. This leads to a moderate to severe anemia with about a 7 to 10 hemoglobin. And don't forget again, Heinz bodies are also in G6PD deficiency. So Heinz bodies in hemoglobin H disease, which is the 3 out of 4 gene deletion, and of course also in G6PD. Manifestations are usually symptomatic at birth, with jaundice and anemia for hemoglobin H disease in alpha thalassemia. Also increased bone marrow hematopoiesis, frontal bossing, and maxilla overgrowth. For diagnosis, it'll have a microcytosis, a hemolytic anemia, schistocytes, teardrop cells, increased reticulocytosis, also target cells as well. They also could have basophilic stippling, increased red blood cell count. Heinz bodies, of course, positive, so Heinz bodies H, and this is in hemoglobin H. They'll have hemolysis, normal or increased serum iron as well due to that lysis, and hemoglobin electrophoresis will be the presence of HBH, beta chain tetramer. For management, episodic blood transfusions can be done. Vitamin C and folate supplementation, which are substrates for the red blood cell production. Also iron chelating agents. Remember, they're iron overloaded from all the lysis. So that would be deferoxamine again. And remove excess iron from chronic transfusions as well. And splenectomy in some cases, and bone marrow transplant is definitive. Next will be for beta thalassemia. Beta thalassemia is a genetic hemoglobinopathy characterized by decreased production of the beta globin chains, leading to excess alpha chains. They're not balanced out. So risk factors more common in Mediterranean as well. And the disease has 3 different ones. So beta thalassemia trait, which is minor, and this is only 1/2 of the abnormal alleles. Beta thalassemia major, which is also called Cooley's anemia, and this is 2 out of 2 abnormal alleles. So, and remember, for the beta alleles, there's only 2 different alleles. For the alpha alleles, there's 4 different alleles. So for the alpha thalassemia, there's 4 different possibilities, and for the beta thalassemia, there's 2 different possibilities. For the clinical manifestations of beta thalassemia, most importantly will be beta thalassemia major, which again is Cooley's anemia, and this leads to ineffective erythropoiesis and a shortened red blood cell lifespan. Clinical manifestations of beta thalassemia major, again Cooley's anemia. Symptoms often occur after 6 months of life when the fetal hemoglobin begins to diminish. They'll have severe chronic anemia, pallor, irritability, dyspnea, mental delays. And for hemolytic anemia, they'll have hepatosplenomegaly as well. They'll have some extramedullary hematopoiesis, very importantly, bony abnormalities, abnormal delayed skeletal development, extramedullary expansion, that's the classic frontal bossing and the hair on end appearance of the skull, also called the crew cut appearance, osteoporosis, and abnormal ribs. For osteoporosis, by the age of 10, hematopoietically active red bone marrow is replaced by inactive yellow marrow, leading to the osteoporosis, compression fractures, and cord compression, potentially scoliosis as well. They could also have some endocrine abnormalities and cardiac dysfunction, leading to heart failure, which would of course be a high output heart failure due to the severe anemia. They could also have enlarged kidneys, and remember, erythropoiesis takes place in the kidneys, so this is due to the increased hematopoiesis in the kidneys. Hemoglobin electrophoresis for beta thalassemia trait, which is minor, they'll have increased fetal hemoglobin, increased hemoglobin A2, however decreased hemoglobin A due to the decrease in the beta chain production. For beta thalassemia major, again Cooley's anemia, this is an increased up to 90% of hemoglobin that's fetal, increased hemoglobin A2, and little to no hemoglobin A. So the CBC in beta thalassemia major will be hypochromic microcytic anemia. They will have a normal or increased red blood cell count, and on peripheral smear we'll see classic target cells or teardrop cells, mostly target cells, some basophilic stippling as well. For skull x-ray, as we said, bossing with the hair on end appearance due to the extramedullary hematopoiesis. And for management for the trait, beta thalassemia trait, no management is typically needed, maybe genetic counseling. If they have moderate disease, we can add folate and also avoid oxidative stress like sulfa drugs. The management for beta thalassemia major, however, it requires frequent transfusions during the periods of increased hemolysis or severe anemia. Iron chelating agents can also be used like deferoxamine to prevent iron overload and remove excess iron from the chronic transfusions. Patients may develop endocrine deficiencies as a result of the iron overload, like hypothyroidism, hypoparathyroidism, gonadal failure, diabetes, or CHF, and vitamin C and folate supplements can be used as well. Splenectomy in some patients, which will help stop the red blood cell destruction as well. And they can do an allogenic hematopoietic cell transplantation as the last line for beta thalassemia major. Next we'll go to macrocytic anemias. So for macrocytic anemias, B12 cobalamin deficiency will be first. Sources of B12 are important to know, and they're mainly of animal origin. This would be meats, eggs, dairy products, and absorption of B12 is important to know. B12 is released by the acidity of the stomach and combines with intrinsic factor, where it is absorbed mainly in the distal ileum. So the stomach notices that there's B12 and secretes intrinsic factor, and it travels with intrinsic factor before getting absorbed in the distal ileum, which is again the third part of the small intestine, the duodenum, jejunum, and ileum. The pathophys is B12 deficiency causes abnormal synthesis of DNA, nucleic acids, and metabolism of erythroid precursors. B12 is needed to convert homocysteine to methionine for the DNA synthesis, so that'll be important. Etiology is decreased absorption. Pernicious anemia is the most common cause. The lack of intrinsic factor due to the parietal cell antibodies, which is leading to gastric atrophy. So antibodies destroy the parietal cells, which are those stomach cells that are secreting this intrinsic factor, and also pancreatic insufficiency as well. Crohn's disease, especially because it affects the terminal ileum, ileal resection, gastric bypass, post-gastrectomy, gastritis, achlorhydria, tropical sprue, Zollinger-Ellison syndrome because of the diarrhea, celiac disease as well due to the lack of villi as celiac disease destroys it, chronic alcohol use, and also meds like H2 blockers and PPIs, which suppress the acidity and from the parietal cells, so that also decreases the intrinsic factor that's secreted by those parietal cells, and also decreased nucleic acid synthesis, such as in metformin, zidovudine, and hydroxyurea, and also anticonvulsants, and lastly fish tapeworm. And it also could be due to competing bacteria as well. So that would be called blind loop syndrome, where bacteria competes for that same B12. It's also important to know a decreased intake is common in vegans due to the lack of consumption of meat and meat products. However, this does take years to develop, and it's not as common with the fortification of foods nowadays. And folic acid only takes a few months, like 4 to 5 months, to be deficient, whereas B12 takes years. Clinical manifestations of B12 cobalamin deficiency is anemia, symptoms similar to folate but associated with neurologic abnormalities. That's the key finding, neurologic abnormalities for B12. Hematologic abnormalities like fatigue, pallor, epithelial glossitis, diarrhea, malabsorption, but most importantly, the neurologic symptoms. These will be in B12 deficiency symmetric paresthesias, most common initial symptom, especially involving the legs, lateral and posterior spinal cord demyelination and degeneration, ataxia, weakness, vibratory, sensory, and proprioceptive deficits, decreased deep tendon reflexes, which is hypotonia. They may have a positive Babinski, so instead of curling down, it curls up the toes, seizures, and psychosis. For diagnosis of B12 deficiency, you want to do a CBC with peripheral smear first, in which you'll see an increased MCV, which is a macrocytic anemia, so that's over 100 femtoliters again, and a megaloblastic anemia, which are hypersegmented neutrophils, and also macroovalocytes. So macroovalocytes also, and a mild leukopenia and thrombocytopenia, and low reticulocytes. You could also do the outdated Schilling's test to determine exactly what the cause of the B12 deficiency is. And a decreased serum B12 level you could do, an increased LDH, importantly, an increased LDH, and increased homocysteine. So if we're not having that breakdown into methionine from homocysteine, then therefore we'd conclude that there'd be a B12 deficiency. Increased methylmalonic acid distinguishes B12 from folate deficiency. So how I remember that it's methylmalonic acid, MMA, and an increased homocysteine is because it's B12, 1 and 2. So there's two different things that are elevated in B12, and there's only one in folate. So MMA is increased in B12, and also homocysteine. However, in folate deficiency, there's no increase in MMA, methylmalonic acid. For management of B12 deficiency, for the route of administration, you want to do oral, sublingual, nasal, IM, deep subcutaneous injections are also possible. And you should also see a very rapid rebound when you're treating them. So a massive reticulocytosis and an increase in hematocrit very quickly. If they are symptomatic, however, or with neurofindings, you want to start with the intramuscular B12 injection. And in adults, IM cyanocobalamin injection is weekly until the deficiency is corrected, and then it's once monthly. Patients can be switched then to oral therapy after resolution of the symptoms. And patients with pernicious anemia also need lifelong monthly IM B12 therapy, or high-dose oral therapy can be done as well. And if it's just a dietary deficiency, which is one of the things that can be determined by the Schilling's test, the oral B12 replacement will be sufficient. As for folate deficiency, we have to know some of the functions of folate. It's required for DNA synthesis, just like B12, and folate deficiency causes abnormal synthesis of the DNA, nucleic acids, and again, metabolism from erythroid precursors. And like we said, folate stores only last for about 2 to 5 months. Etiologies is inadequate intake, which is the most common cause, especially with alcoholics or an unbalanced diet, or increased requirements, especially in pregnancy, infancy, hemolytic anemias, malignancy, and psoriasis. So remember, in psoriasis, the pathophysiology of that is increased cell turnover in the skin. So due to the increased cell turnover, we're burning through a lot of DNA precursors, so that's why you can have a folate deficiency in psoriasis. Also impaired absorption, similar things to B12 deficiency, like celiac disease, IBD, chronic diarrhea, anticonvulsants like phenytoin, phenobarbital, carbamazepine, and of course impaired metabolism through methotrexate, which inhibits folate, trimethoprim sulfamethoxazole, mostly the trimethoprim component, pentamidine, and also anti-seizure agents, again phenytoin, carbamazepine, or also lost just through things like dialysis. Manifestations of folate are a bit different from B12, where anemia symptoms are similar to B12 but without the neurologic abnormalities. So with folate, no neurologic abnormalities. They may have some pale, faintly green complexion, however that's rare, in epithelial, glossitis, aphthous ulcers, diarrhea, malabsorption, and of course the typical hematologic manifestations like fatigue, exercise intolerance, pallor. For diagnosis, you want to do, first of all, CBC with peripheral smear, in which you'll see an increased MCV, a macrocytic anemia, plus a megaloblastic anemia, hypersegmented neutrophils, and macroovalocytes. So those macroovalocytes are in both the B12 as well as the folate deficiency. Low reticulocytes, and potentially a pancytopenia. Decreased folate levels, increased LDH, just like in B12, increased homocysteine, just like in B12, but a normal MMA, a methylmalonic acid, which is classically what distinguishes folate from B12. So MMA, so there's no MMA elevation in folate. For management, oral folic acid, you could do parenteral in severe folic acid deficiency. Replacing folic acid in patients with a B12 deficiency may correct the anemia, but neurologic symptoms will worsen. So that's something to note. If you replace it in folic acid, if you replace folic acid in patients with the B12 deficiency, it corrects the anemia, so you also have to look at those neuro symptoms. So again, an exam tip, in B12 and folate, anemia, macrocytosis, macroovalocytes, decreased reticulocytosis, increased homocysteine, increased hypersegmented neutrophils. However, B12 only will have neurologic and increased MMA, that methylmalonic acid. And of course, folate, no neurosymptoms, and a normal MMA. So some of the causes of a macrocytic anemia overall, the two that we just went over, B12, cobalamin deficiency, as well as folate deficiency, chronic liver disease, alcoholism, hypothyroid, and also myelodysplastic syndrome and acute leukemia. So now we'll go into the normocytic anemias. So for normocytic anemias, the etiologies are anemia of chronic disease, this is the most common, as well as renal and mixed disorders like iron and B12 deficiency, endocrine, early iron deficiency, asplenia, also dilutional. If we're just giving a lot of fluids on CBC, it will look like they're having lower values, sickle cell, as well as G6PD. So next we'll go over anemia of chronic disease. So anemia of chronic disease is a decrease in red blood cell production in the setting of chronic disease. Etiologies are a chronic inflammatory condition like a chronic infection, inflammation, autoimmune disorders, and malignancy. There's three major factors that lead to the decrease in iron. It could be increased hepcidin. Hepcidin is an acute phase reactant that blocks the release of iron from macrophages and reduces GI absorption of iron. So your body's sensing that there's some kind of inflammatory process going on, and it wants to decrease the amount of iron in the blood. So hepcidin is something that will do that. So when your body notices that acute phase reactant hepcidin is present, it'll reduce the GI absorption and reduce the release from macrophages. So again, that's an increased hepcidin. And also increased ferritin. So increased ferritin. Ferritin is an acute phase reactant that sequesters iron into its storage, and also erythropoietin inhibition via cytokines. So it keeps the iron away from the blood, as if to hide it from the bacteria, is the way you can think of it. For diagnosis, CBC, a mild normocytic normochromic anemia, may present with microcytic hypochromic early on, and hemoglobin is not usually under 9. Decreased reticulocytes, or a normal to increased red blood cell distribution width. For iron studies, it'll be normal or increased ferritin, and a decreased TIBC, the body is hiding the iron, and a decreased serum iron, which would be a decreased ferritin, and a TIBC, which may be within normal limits. So again, the iron studies overall for anemia of chronic disease. Normal to increased ferritin because it's that acute phase reactant in the inflammatory condition, and a decreased TIBC. So the body doesn't want more iron, so there's less total iron binding capacity. The body's hiding the iron that's already there. Remember, due to that increased hepcidin and that increased ferritin. For the management is erythropoietin alpha, so that's darbepoetin, if renal disease or low erythropoietin levels. So in chronic kidney disease, that's one of the main causes, and that'll decrease the erythropoiesis. So for an exam tip, we have iron deficiency anemia, which is a microcytic hypochromic, decreased ferritin, decreased serum iron, and increased TIBC because we need more iron. Anemia of chronic disease, however, normochromic, normocytic, maybe micro early on, increased ferritin and decreased TIBC. For thalassemia, microcytic, hypochromic, normal or increased ferritin, but importantly normal or increased serum iron. Next we'll be going through the variety of different hemolytic anemias. So going through many, understanding hemolytic anemias will be the anemia caused by an increased red blood cell destruction when the rate of destruction exceeds the bone marrow's ability to replace the destroyed cells. There are two main types, intrinsic and extrinsic. So intrinsic is inherited. So intrinsic, inherited, that'll be like sickle cell, thalassemia, G6PD, hereditary spherocytosis. And extrinsic is an acquired condition. So that's an autoimmune hemolytic anemia, DIC, TTP, HUS, paroxysmal nocturnal hemoglobinuria, or a hypersplenism. For diagnosis, you want to do, of course, the peripheral smear, in which you'll see increased reticulocytes, the immature red blood cells, also schistocytes, the bite cells, if intravascular hemolysis. Haptoglobin is decreased. Haptoglobin is decreased because it becomes depleted when it binds to the free hemoglobin with the continued red blood cell destruction. So haptoglobin is that molecule that binds when free hemoglobin is released. So of course, if there's more free hemoglobin from the hemolysis, then we're going to have decreased haptoglobin because that had to bind to it. And also an increased indirect bilirubin due to the increased red blood cell destruction, which overwhelms the liver's ability to convert direct bilirubin. So the conversion is by that UGT enzyme, remember. So decreased haptoglobin, increased indirect bilirubin, and also an increased reticulocyte count. So increased reticulocyte count because the body's response to an increased red blood cell destruction. So the baby red blood cells, the reticulocytes, are attempting to replace the mature red blood cells, which are destroyed. So of course that gives us an increased red cell distribution width as well, because we're pumping out more larger baby red blood cells, the reticulocytes. And also an increase in LDH because it's an enzyme that's released from destroyed red blood cells. So any kind of hemolysis, we're going to have that increase in LDH as well. So again, one more time, haptoglobin decreased, indirect bilirubin increased, reticulocytes increased, and LDH increased in hemolytic anemias. An intrinsic hemolytic anemia is inherited, and extrinsic is acquired. So in order to distinguish some of the main points here, we'll go through them. So sickle cell anemia, these are of course sickled cells on peripheral smear, hemoglobin S on hemoglobin electrophoresis. For thalassemia, thalassemia is typically a microcytic anemia with a normal or an increased serum iron because the spleen kind of lyses them, or no response to an iron treatment. So if we're treating them with iron and they're not getting better and we suspected iron deficiency anemia, we want to suspect then thalassemia. And also thalassemias are associated with severe anemia and an abnormal peripheral smear for a given hematocrit level. Again, alpha thalassemia on electrophoresis will have a normal hemoglobin ratios of hemoglobin A, A2, and F, or hemoglobin H. Remember, that's that Bart's. Alpha thalassemia is a diagnosis of exclusion, since the peripheral smear is often normal. And for beta thalassemia, on hemoglobin electrophoresis will be a decrease in hemoglobin A, increase in hemoglobin A2, and increase in fetal hemoglobin. For G6PD, this will be episodic. So G6PD episodic hemolytic anemia associated with sulfa drugs, favabeans, infections, and remember that's your DNP for G6PD. DNP, dapsone, nitrofurantoin, and primaquine are some of the drugs that cause that as well. Hereditary spherocytosis, this will be microspherocytes and Coombs negative, also a positive osmotic fragility test. Autoimmune hemolytic, you could have microspherocytes and a Coombs positive. And remember, there's two types of the autoimmune hemolytic anemia, which you can have the cold or warm agglutinins. The cold agglutinins gets that autoagglutination, and the warm agglutinins does not. TTP and HUS still have normal coag panels, and it's unable to distinguish this between TTP and hemolytic uremic syndrome on labs. So TTP, thrombotic thrombocytopenic purpura. And for TTP, that's the pentad, your fat RN, fever, anemia, thrombocytopenia, renal and neurologic problems. And for hemolytic uremic syndrome, that's your E. coli 0157H7, which is the most common cause. That's thrombocytopenia, hemolytic disease, kidney damage with an increased creatinine, and hemolytic uremic syndrome is more common in children, especially with the diarrheal prodrome. And it has a higher association with renal problems than TTP, but does not classically have a fever or neurosymptoms, so you can help differentiate TTP from HUS from that. And also, of course, HUS, the biggest factor is that they had that E. coli, the enterohemorrhagic E. coli just previously. And also for HUS, one more thing, we'll go over it more later, but is the lack of antibiotics that we should give. So we should not give antibiotics because that'll lyse the bacteria and lead to more toxins and spores inside the blood, so it's even worse for them. For disseminated intravascular coagulation, this is the only one that'll have abnormal coagulation factors. They're all getting used up, so they'll have a prolonged PT and a PCT. And paroxysmal nocturnal hemoglobinuria, this is dark urine that's worse in the morning. So we'll go into all those disorders in some more depth. So hereditary spherocytosis. This is an autosomal dominant hereditary intrinsic hemolytic anemia, some recessive forms as well. It's a deficiency in red blood cell membrane cytoskeleton. It's the protein spectrin, which leads to an increased red blood cell fragility and a sphere-shaped red blood cell. So sphere-shaped and a lack of spectrin due to the cytoskeleton. And these abnormal red blood cells are detected and destroyed by the spleen, so this leads to the hemolysis. Manifestations, broad spectrum of clinical symptoms. Mild cases may present in adulthood, some jaundice. Also recurrent episodes of hemolysis, like anemia, jaundice, splenomegaly. And pigmented gallstones is important to know for this. So that'll be that dark pigment from the hemolysis. Diagnosis will be on peripheral smear with a hyperchromic microcytosis, 80% spherocytes, the rounded red blood cells, which lack that central pallor. They may have a hemolytic smear as well with schistocytes and increased reticulocytes. Increased MCHC is the most reliable, the mean corpuscular hemoglobin concentration, and increased red blood cell distribution width. So a bunch of different ones increasing that range. And the MCHC, the mean corpuscular hemoglobin concentration, due to the sphere as well. Hemolysis, increased indirect bilirubin, decreased haptoglobin. EMA binding is the preferred test and the most accurate test. Could also do the osmotic fragility test and the negative Coombs test. So Coombs negativity distinguishes hereditary spherocytosis from autoimmune hemolytic anemia. Management is folic acid, but it's not curative, and splenectomy is curative in severe or refractory cases. But importantly, for hereditary spherocytosis, the splenectomy should be delayed in children until at least 4 years of age, after the risk of developing sepsis has peaked. And of course, anti-pneumococcal vaccine should be given prior to splenectomy, an important point for hereditary spherocytosis. Next will be autoimmune hemolytic anemia. Autoimmune hemolytic anemia is acquired hemolytic anemia due to autoantibodies against the production of red blood cells. It could be warm or cold. If it's warm, it's IgG antibodies activated by protein antigens on the red blood cell surface at body temperatures, leading to red blood cell destruction by splenic macrophages, or a complement 3 activation. It could be SLE, rheumatoid arthritis, CLL. So importantly for warm, it's IgG and it's normal body temperatures. So IgG, normal body temperatures, warm, autoimmune hemolytic anemia. For cold, it's IgM antibodies against the polysaccharides of the red blood cell surface, which induce intravascular complement-mediated red blood cell lysis, especially at colder temperatures. And that's that IgM molecule binding, leading to that autoagglutination, as we showed earlier. So cold, IgM, complement-mediated lysis, colder temperatures, and that's that IgM leading to the agglutination. Etiologies for warm agglutination: idiopathic, also penicillins, cephalosporins. SLE is an important cause. Cold agglutinin disease is most commonly by infection, like mycoplasma or Epstein-Barr virus or HIV. Two important ones are mycoplasma and EBV for a cold agglutinin disease. Clinical manifestations: typical anemia symptoms, pallor, fatigue, weakness, dyspnea, hemolysis, hemoglobinuria, jaundice, splenomegaly. For cold-induced vascular phenomenon, in cold-induced autoimmune hemolytic anemia will be acrocyanosis, and that'll be the numbness or mottling of the fingers, toes, nose, or ears. It does resolve with warming up of those body parts, however. Diagnosis will be CBC and peripheral smear. You'll see a decreased hemoglobin and some hemolysis as well, and reticulocytosis. Microspherocytes, especially in warm. And remember, we said warm, more common to be those autoimmune conditions, SLE, rheumatoid arthritis, with the IgG. And for labs, hemolysis and a positive direct Coombs test. So a positive direct Coombs test. And that's how we differentiated it from the hereditary spherocytosis, where hereditary spherocytosis had a negative Coombs test. It was more a spectrin or cytoskeleton problem with the red blood cells, whereas the autoimmune condition has a positive direct Coombs antiglobulin test, and a positive IgG for this one, and C3 positivity is the most accurate test in warm. So two different managements for warm and cold. For warm agglutinin autoimmune hemolytic anemia, first line is glucocorticoids if symptomatic. Second line is splenectomy or rituximab, that's that anti-CD20 if no response to glucocorticoids. And for cold agglutinin, you just want to avoid cold temperatures as the mainstay of treatment because that precipitates it. If it's severe, you could do transfusions or plasmapheresis as well. So for warm, glucocorticoids, splenectomy or rituximab if no response, and for cold, avoid the cold temperatures. So next will be sickle cell disease. The pathophysiology of sickle cell disease is a point mutation where valine substitutes for glutamic acid on the beta chain. Sickle hemoglobin HbS has a decreased solubility under hypoxic conditions, leading to conformational changes of the red blood cell shape, which leads to that sickling, with subsequent vaso-occlusion, microthrombosis, and hypoxia. Sickled cells are destroyed by the spleen, which is hemolytic anemia. So valine bumps out the glutamic acid. Someone said Val kicks butt with the glutes, so kicks out the glutamic acid, and valine does that. So valine substitutes the glutamic acid, important to know. Sickle cell trait is different than disease. So sickle cell trait is heterozygous, and that's 8% of African Americans overall. Patients with the sickle cell trait are usually asymptomatic and are not anemic unless exposed to severe hypoxia, extreme physical stress, high altitudes, or dehydration. They may develop an episodic hematuria or isothenuria, which is due to papillary necrosis. For sickle cell disease, on the other hand, this is a homozygous sickle mutation, SS. This is 0.2% of African Americans. The main clinical manifestations are due to a hemolytic anemia and vaso-occlusion, acute or chronic pain, tissue ischemia, or infarction. For sickle cell trait overall, this is a heterozygous trait, as we said, AS, 8% of African Americans, and it's more common in populations where malaria is endemic. The pathophys is about 20 to 25% of their hemoglobin is HbS. Manifestations: patients with sickle cell trait are usually asymptomatic, and they're not symptomatic unless exposed to severe hypoxia, extreme physical stress, low temperatures, high altitudes, or dehydration. They may develop episodic hematuria or isothenuria, which is again due to that papillary necrosis. And for diagnosis, hemoglobin electrophoresis. This is where you find the presence of both hemoglobin A and hemoglobin S, where the amount of hemoglobin A is greater than S. So that's classic FAS pattern in neonates. So hemoglobin A is greater than hemoglobin S, HbA over HbS. Peripheral smear is usually normal hemoglobin and hematocrit, reticulocyte count, and peripheral smear. And for management overall, sickle cell trait usually does not require treatment. and a painful crisis is not a component of the trait. For papillary necrosis, that's that isothenuria, we want to do conservative measurements. For sickle cell disease, on the other hand, this is a group of inherited disorders affecting the beta globin chain, leading to production of red blood cells that sickle, causing hemolysis and vaso-occlusive disorders. So there's many things to know for sickle cell disease. Symptoms usually begin as early as 6 months, when the hemoglobin sickle cell replaces the fetal hemoglobin. Dactylitis is the most common initial presentation. This delays growth and development, as well as leading to fevers and infections. For infections, it's important to know a couple different ones: functional asplenia and autosplenectomy. From repeated splenic infarctions is often between 1.5 to 3 years old, and it leads to an increased risk of infections from encapsulated organisms, from strep pneumoniae, H. flu, Neisseria meningitidis, group B strep, Klebsiella, and Salmonella, importantly. So that's functional asplenia, and remember, they'll be autoinfarcted of the spleen in 1.5 to 3 years old, most commonly. And again, the risk for those encapsulated organisms. Osteomyelitis is also a risk with Salmonella species. This is the most common organism in patients with sickle cell disease. Aplastic crisis is commonly associated with parvovirus B19 as well. So 3 things for infections with sickle cell disease: the functional asplenia in those encapsulated organisms, osteomyelitis due to Salmonella, and aplastic crisis due to that parvovirus B19. They can also have a splenic sequestration crisis, which is vaso-occlusion in the spleen and red blood cells pooling in the spleen, leading to an acute splenomegaly and a rapid decrease in hemoglobin. This occurs most often in children, however. Hemolytic anemia, jaundice, gallstones, pigmented gallstones, due to that unconjugated bilirubin, and painful vaso-occlusive crises. These are triggered by hypoxia, cold weather, infection, dehydration, alcohol, and pregnancy. It's associated with an abrupt onset of pain, acute chest syndrome, back, abdominal, or bone pain. And remember, that's very important, the acute chest syndrome, or the back, abdominal, and bone pain. They can also have priapism as well. Acute chest syndrome is important to know: fever, cough, tachypnea, oxygen desat, and chest pain. Or a bony vaso-occlusion. This is commonly avascular necrosis, ischemic necrosis of the bones, most commonly in the femoral and humeral heads, and also skin ulcers, especially in the tibia, chronic hypoxia, pulmonary hypertension, CHF, fatigue, dyspnea, and stroke. 25% have one by the age of 45, and 25% of the children have silent episodes of it as well. So very important to know the clinical manifestations there. For diagnosis, peripheral smear will be the best initial test, and we'll have target cells and sickled erythrocytes, of course, most commonly, decreased hemoglobin, about 8 to 10 is typical, and a decreased hematocrit as well. And they'll also have the classic Howell-Jolly bodies, indicates a functional asplenia as well. So again, that's that decreased splenic function with the things left over inside the red blood cell itself. Hemoglobin electrophoresis, sickle cell disease, hemoglobin S, little to no hemoglobin A, and an increased hemoglobin F. Sickle cell trait will have HbS and a decreased HbA. So again, sickle cell disease, HbS for sickle, little to no HbA, and an increased HbF, fetal hemoglobin. For management overall, it's going to be a lot of pain control, also with IV hydration, fixing the stressors, and oxygen as the first step in management of the painful crises. Reverses and prevents the sickling. Also, meperidine is not recommended in patients with sickle cell disease, which may lead to seizures and renal failure at high doses. Folic acid supplementation and red blood cell transfusion therapy may be needed for some patients in acute crises, like acute chest syndrome, splenic sequestration, or a pre-op transfusion. Also, some patients may actually be allergic to the transfusion, so you can do Benadryl beforehand to decrease the allergic reaction if they do have one. An exchange transfusion therapy is used if there is severe vaso-occlusive crisis, like acute chest syndrome, stroke, priapism, retinal infarction leading to visual changes. Also, allogeneic stem cell transplant. It's the only potential curative treatment for sickle cell, but has significant side effects. For reduction in episodes, there's a few therapies that we should know, hydroxyurea being the most common. The mechanism of action is increases production of fetal hemoglobin, which does not sickle and has a higher affinity for oxygen, increases red blood cell water, and reduces the red blood cell sickling, altering the red blood cell adhesion to the endothelium. This takes weeks to start working, however. Hydroxyurea does. Indications are the mainstay of treatment in sickle cell disease, reducing the frequency and severity of painful episodes, decreasing the hospital rates, and prolonging survival as well. And also because it takes weeks to months to fully take effect, it's not used for acute episodes. The uses are sickle cell disease, polycythemia vera, and essential thrombocytopenia. The combination of hydroxyurea and L-glutamine have additive benefits. So L-glutamine is kind of a new treatment. It's seen in sickle cell patients being used. It's called Endari, and this helps decrease the oxidative forces. So it starts by helping the glutathione antioxidant system from decreasing those oxidative forces. So that's Endari, which is L-glutamine, which is also helpful in conjunction with hydroxyurea. Adverse effects of hydroxyurea are myelosuppression and infection prevention. It's important to know for children. So in patients with sickle cell disease, functional asplenia and autosplenectomy from repeated splenic infarctions, often by 1.5 to 3 years of age, lead to an increased risk of infection with encapsulated organisms. That's Strep pneumoniae, H. influenza, Neisseria meningitidis, and group B strep, Klebsiella, and Salmonella. And remember again, Salmonella osteomyelitis is most commonly associated with sickle cell disease. Prophylactic penicillin is given as early as 2 to 3 months of age until at least 5 years of age to prevent infectious complications. Pneumococcal and influenza vaccines also help to reduce mortality too. So pneumococcal and influenza vaccines help reduce mortality as well. For exam tip, it's important to know the difference between an aplastic crisis and splenic sequestration. So in both of them, aplastic crisis and splenic sequestration will have a rapid drop in hemoglobin and also a thrombocytopenia. Both may be caused by parvovirus B19 infections. For an aplastic crisis, however, there'll be a drop in reticulocytes as well, and also a mild neutropenia. In splenic sequestration, there'll be a reticulocytosis, a rapidly enlarging spleen, hypovolemia, and thrombocytopenia. So in splenic sequestration, the spleen's just sequestering all of those red cells, and therefore there'll be a responsive reticulocytosis, where in an aplastic crisis, there's just a drop in everything, including the reticulocytes, and also a neutropenia and a thrombocytopenia. Next, for paroxysmal nocturnal hemoglobinuria. So this is a rare acquired stem cell mutation. This is when the red blood cells become deficient in a GPI anchor surface protein. That's the CD55 and 59. The pathophys is CD55 and 59 normally protect the red blood cells from complement destruction. Deficiency in any of these proteins leads to an increased complement activation and an intravascular red blood cell destruction. So this hemolysis can be dramatically increased during a viral or a bacterial infection due to the antigen-antibody reactions. Clinical manifestations would be a triad of hemolytic anemias, a hemoglobinuria, plus a pancytopenia and unexplained thrombosis in atypical veins. So hemoglobinuria, pancytopenia, and unexplained thrombosis in an atypical vein. Hemolytic anemia will have a dark cola-colored urine, especially during the night or early morning, with a partial clearing during the day, importantly. Venous thrombosis of the large vessels due to haptoglobin and nitric oxide depletion, thrombosis in unusual veins as well, like hepatic, cerebral, abdominal, subdermal veins. Pancytopenia as well. Hypercoagulability despite pancytopenia is hallmark. And for diagnosis, you'll see hemolysis, increased indirect bilirubin, LDH, decreased haptoglobin, and also hemoglobinuria, increased reticulocytes, and a hemosideриnuria. You can do flow cytometry, which is the best test to look for the paroxysmal nocturnal hemoglobinuria. and a red blood cell fragility test, which we also saw in the spherocytosis, with Coombs negativity. So again, that Coombs negativity and fragility was seen in the spherocytosis, and the Coombs positivity in autoimmune hemolytic anemia. For management of PNH, this is eculizumab, which is a complement inhibitor. So eculizumab, also ravulizumab, which has a longer half-life. So eculizumab is an anti-complement antibody targeting the C5 complement compound. So eculizumab. Folic acid supplementation. Also, allogeneic hematopoietic cell transplantation is the only potential for a cure. So next we'll go into hemostasis. Hemostasis overall is the process of stopping bleeding, which prevents exsanguination from lacerations or other injuries, and there's two main phases, the primary hemostasis and the secondary hemostasis. So in primary hemostasis, this is platelets, which form a platelet plug at the site of vascular injury. Overall, it's platelet adhesion, activation, and then aggregation. Platelets adhere to the site of injury, becoming activated, sending out ADP and thromboxane A2, which respectively are being blocked by clopidogrel for ADP and thromboxane A2 by aspirin, which attract other platelets to aggregate, forming a platelet plug. Some of the disease examples which occur in primary hemostasis are thrombocytopenia, which is ITP, TTP, HUS, hemolytic uremic syndrome, DIC, and von Willebrand's deficiency. Disorders that affect platelets will affect primary hemostasis, also bleeding time, the immediate bleeding after a surgery, but PT and PTT are usually unaffected. Clotting factors are unaffected. So PT and PTT are usually unaffected in primary hemostasis. This is more of a platelet thing. These diseases classically cause petechiae and mucocutaneous bleeding, oral GI or hemorrhages. And then secondary hemostasis. These are the clotting factors, which are proteins, which are made by the liver, 2, 7, 9, and 10. And they respond in a cascade form to form fibrin strands, which strengthens the platelet plug that was formed during the primary hemostasis. Disease examples which affect the secondary hemostasis are hemophilia A and B, DIC as well, and von Willebrand's disease as well. Disorders that affect the extrinsic pathway prolong the PT, which is the warfarin side of things, and the intrinsic pathway, which is the prolonging of the PTT, which is the heparin side of things. So these diseases classically cause delayed, deep bleeding, hemarthrosis, bleeding into the joints and muscles, or delayed bleeding after surgery. So the PTT and the PT are two different things. The PTT is the partial thromboplastin time. This measures the efficacy of the intrinsic and common coagulation pathway. Normal PTT time requires the presence of factors 1, 2, 5, 8, 9, 10, 11, and 12. And also for prolonged PTT, it's important to know heparin, DIC, von Willebrand's disease due to its effect on factor 8, hemophilia A and B, and antiphospholipid antibody syndrome, which paradoxically increases thrombogenicity. Heparin overdose as well is important to know, which is protamine sulfate. PT, which is the prothrombin time, this measures the extrinsic, the tissue factor pathway, and the common pathway. So normal PT times primarily require the presence of a factor 1, 2, 5, 7, 9. So 2, 5, 7, 9, and 10 are all made by the liver as well. And a prolonged PT will be in warfarin therapy or vitamin K deficiency, also in DIC. Warfarin overdose antidote is, of course, vitamin K. Next, we'll go into some of those thrombocytopenias. So first will be thrombotic thrombocytopenic purpura, TTP. This is a thrombotic microangiopathy resulting from Adams TS13 deficiency. So the pathophys is Adams TS13 is a von Willebrand factor cleaving protease. Adams TS13 deficiency leads to large von Willebrand factor multimers that cause small vessel thromboses. So Adams TS13 typically cleans up the extra von Willebrand's factors that are stuck to the endothelium. So basically it clips off all the extra aggregation and activation that von Willebrand's disease did in the primary hemostasis and make sure that we're not overclotting. So without that, you can imagine that you'd have a lot of thrombosis. So it affects, there's two different etiologies for TTP. Primary, which is idiopathic or autoimmune, which is antibodies against the Adams TS13. And there's also secondary, which is most importantly SLE, but also malignancy, bone marrow suppression, also pregnancy, but mostly SLE. Clinical manifestation, this is the classic pentad of the fat RN, fever, anemia, which is that microangiopathic anemia, thrombocytopenia, also renal phenomenon and neuro. So for that thrombocytopenia, this will cause mucocutaneous bleeding. That's epistaxis, bleeding gums, petechiae, purpura, bruising, and menorrhagia. For the microangiopathic hemolytic anemia, that's anemia, jaundice, fragmented red blood cells, which are schistocytes, and also splenomegaly, neurologic symptoms, fever, kidney failure, or uremia. For diagnosis, you want to see thrombocytopenia with normal coag studies, so seen in both TTP and hemolytic uremic syndrome. And normal coag studies, PT and PTT, help to distinguish TTP and HUS from DIC, which DIC is the only one with increased coagulation studies. Hemolysis is important. Peripheral smear, you'll see those schistocytes as well. Increased LDH, increased bilirubin, unconjugated, and also decreased haptoglobin. And of course, a decreased Adams TS13 and a Coombs test negative, increased bleeding time overall. For management of TTP is very important. Without the treatment, they can actually die, and before we had treatment for this, there was a very high mortality. And the treatment is plasmapheresis. This is the initial treatment of choice. Plasmapheresis removes the antibodies that attack the Adams TS13 and adds Adams TS13 to the serum, in which you'll monitor the LDH to platelets until normal every 2 days. So never give straight platelets to these patients, as giving them more for von Willebrand's disease to actually form those clots. So remember, we're having that lack of the Adams TS13 to clean up after all the extra von Willebrand's factors do too much clotting with all those platelets. So if we're giving more platelets, we're just giving more food for the von Willebrand's factor to form those extra platelet plugs. We also have to think about that plasma exchange, plasmapheresis. If it doesn't work, then we can do rituximab or glucocorticoids, and that's immunosuppression. So it is autoimmune in nature. So if plasmapheresis doesn't work, you want to do glucocorticoids and or rituximab. Next will be HUS, hemolytic uremic syndrome. HUS is a thrombotic microangiopathy due to platelet activation by exotoxins. So this is a triad, not a pentad, of thrombocytopenia, hemolytic anemia, and renal dysfunction, uremia. Fever and neurologic symptoms, which are seen in TTP, are often absent in HUS. This is predominantly seen in children with a recent history of gastroenteritis, HUSs, and in adults it's associated with SLE, antiphospholipid, also chemo drugs like bleomycin and cisplatin. Pathophys will be D+, HUS, which is classic. This is associated with diarrhea, prodromally, exotoxins like shigotoxin, Shiga-like toxin in the enterohemorrhagic E. coli, that's at O157H7, which enters the blood where damage to vascular endothelium has taken place, and therefore activates platelets, microthrombi form, and eventually depleting the platelets overall. The toxins preferentially damage the kidneys, leading to a uremia. The DHUS is atypical, and it's not associated with diarrhea. And the PHUS is Streptococci pneumoniae, which releases neuraminidase, which initiates the inflammatory reaction. Manifestations are a prodromal diarrheal illness, most importantly, also abdominal pain, bloody diarrhea, nausea and vomiting, and renal involvement, oliguria and hematuria. They'll have typical physical exam signs of anemia. And labs are also the same in TTP and HUS. They'll have that thrombocytopenia with the normal coag panel seen in both TTP and HUS, and also normal coag studies. The PT and the PTT help to distinguish TTP from HUS and DIC. So HUS and TTP are the same for the coag panel, and DIC is the only one with that abnormal coag panel. You also see hemolysis in HUS and schistocytes, increased BUN and creatinine, Coombs negative, and an increased bleeding time because we're dealing with the platelets. For management, supportive is the initial management of choice. Fluid and electrolytes, dialysis if needed, and discontinuing any nephrotoxic meds, and a red blood cell transfusion if severely anemic. Plasmapheresis can be done if severe, and antibiotics and antimotility agents are usually avoided because they can worsen the condition, especially if it's from the enterohemorrhagic E. coli, which if you try to kill the bacteria, it releases even more toxins, so it's more toxic. So no antibiotics or antimotility agents in hemolytic uremic syndrome or that enterohemorrhagic E. coli 0157H7. So next we'll go over disseminated intravascular coagulation. This is a pathological activation of the coagulation system. For pathophys, it's uncontrolled fibrin production due to tissue factor activation, leading to a widespread microthrombi, which consumes coagulation proteins 5, 8, and fibrinogen and platelets. And also consumption then leads to severe thrombocytopenia, manifesting as a diffuse bleeding from the skin, respiratory, GI tract, basically bleeding from everywhere. Microthrombi lead to organ ischemia as well. So basically everything's used all up, and they're also seen in mostly severely sick patients with an underlying serious condition. Some of the etiologies are infections with gram-negative sepsis, and malignancies, AML it could be seen in, also GI, lung, and prostate malignancies, also obstetric in preeclampsia, and 50% of patients with abruptio placentae or amniotic fluid embolism have evidence of DIC, also septic abortions, massive tissue injury, trauma and burns, liver disease, aortic aneurysms, and also ARDS. So these are all severely sick patients that are using up all their clotting factors and they're diffusely bleeding. So bleeding is classically oozing from the venipuncture sites, catheters and drains, and extensive bruising. Thrombosis will be seen, arterial or venous, in gangrene or multiple organ failure, especially renal and hepatic. Diagnosis, it's important to know, will be a decreased fibrinogen. From all the consumption of the fibrinogen to form those fibrin clots, it's being all used up. Bleeding will be an increased PT, PTT, and INR. So remember, PT and INR are both in that extrinsic pathway as well. And also thrombocytopenia, of course, all those platelets are getting used up. Everything's getting used up in DIC. They'll have an increased D-dimer because D-dimer is a fibrin degradation product. So increased fibrin, therefore increased fibrin degradation over time. And that's that fibrinolysis. Decrease in fibrinogen since it's used up to form the clot in the first place. And on peripheral smear, there'll be some fragmented red blood cells and also schistocytes. For management, you want to treat the underlying cause as the mainstay of treatment, and platelet transfusion if the platelets are low, but if they're not actively bleeding. FFP if severe bleeding, which replaces the coag factor, so that's important. And cryoprecipitate replaces fibrinogen in patients with severely low levels. Heparin for thrombosis in some patients can be done as well. Next we'll go into immune thrombocytopenic purpura, ITP. So ITP is an acquired, immune-mediated, isolated thrombocytopenia. So it's just a low platelet count. Pathophysiology, autoantibodies against platelets leading to a splenic destruction of the platelets. The autoantibodies develop against the GP2B3A receptor of the platelets. So it is splenic sequestration, but only to the platelets itself because they've had some autoantibodies attached to them, to only the platelets. In primary ITP, it's idiopathic. It's most common after a viral infection, and it's self-limited. In secondary ITP, immune-mediated, but often associated with an underlying disorder, especially SLE, HIV, HCV, antiphospholipid syndrome, and SLE. And it's more common in adults, and it's usually recurrent as well. So primary is more common in kids after a viral. Secondary is more common with underlying disorders, again, like HIV, HCV, and it's usually recurrent. It could be asymptomatic. They could have mucocutaneous bleeding, like epistaxis, bleeding gums, petechiae, purpura, bleeding, menorrhagia. And severe bleeding is not common. Not common. So intracranial hemorrhage, possible but not common in ITP. And it's not associated with splenomegaly. So it's not associated with splenomegaly, even though the spleen is destroying all those platelets that are tagged with the autoantibodies. There's no splenomegaly. For diagnosis of ITP, it'll be an isolated thrombocytopenia with normal coag panels like PT, PTT, and INR, and a normal white blood cell count as well. Also a normal hematocrit. No schistocytes. There's no turbulent ride in the vessels that are destroying those red blood cells. The bleeding time may be elevated because it is thrombocytes that are low. Bone marrow will see megakaryocytes, which are large-sized platelets. And marrow testing is usually reserved for older patients and non-responsive patients. This is overall a diagnosis of exclusion, ITP is. So again, that's the megakaryocytes seen in bone marrow. For management in adults is different from management in children. So ITP management in adults for mild bleeding in platelets under 30,000, glucocorticoids will be first line to blunt the immune response, then IVIG second line. You can also, if it's refractory, do rituximab or splenectomy. So severe bleeding, GI or CNS, platelet transfusion, and remember, we'd never do a platelet transfusion in TTP. However, platelet transfusion, IVIG, and high-dose glucocorticoids. So you do all three for severe bleeding. And if they're having no bleeding and their platelets are over 30,000, then you can do observation. So it's kind of on a spectrum for management in adults, however, where if it's mild bleeding under 30,000, IVIG and glucocorticoids, and then rituximab or splenectomy. Severe bleeding, give them everything. No bleeding, just observe. And for children, no bleeding or mild bleeding or not at risk, observation. IVIG if there's a rapid rise in platelet counts that are required. And for glucocorticoids, you should do this if it's an increased risk for bleeding, but a rapid rise in platelets is not necessarily needed. And of course, if there's life-threatening bleeding, IV glucocorticoids plus IVIG. So next we'll go into hemophilia A. This is a factor VIII deficiency. So it's an X-linked recessive disorder occurring almost exclusively in males, rarely females, and it can also be caused by spontaneous mutation. It's the most common type of hemophilia, and the first episode is usually under 18 years of age. It's a lack of factor VIII that affects the clotting cascade, leading to a failure of hematoma formation. So clinical manifestations will be hemarthrosis, most commonly, 80%, swelling out of proportion to the injury itself, delayed bleeding or swelling in weight-bearing joints like the ankles, knees, elbows, soft tissues, and muscles, forehead hematomas, also excessive hemorrhage due to trauma and surgery, or incisional bleeding, especially even from like tooth extraction. Epistaxis is possible, also bruising, GI or urinary tract hemorrhages. And how we can remember deficiency in factor VIII is 8. So you say 8 or A, sounds very similar, so you can use that to remember hemophilia A is a factor VIII deficiency. Hemophilia less commonly presents with purpura, petechiae, because the platelet function is normal, and these would be findings of platelet dysfunction, or spontaneous hemorrhage, except for in the severe form. So for a diagnosis of hemophilia A, it'll be a prolonged APTT, which again is that intrinsic pathway, and a normal PT, which is factor VII, which is that extrinsic pathway as well. For mixing studies, PTT is corrected with the mixing studies due to the factor deficiency, and a low factor VIII is the most sensitive test. For management, it's important to know the management. There's a ton of questions on this. What's the management for hemophilia A? It's factor VIII infusion, which is the first line therapy. And you want to increase the levels 25 to 100% depending on the severity, It can be given in response of an acute bleeding episode, or it could be given prophylactically, like prior to surgery or after trauma. However, it's also important to know desmopressin, DDAVP. This is transiently increasing factor VIII and von Willebrand's factor release from the endothelial stores, so it may be used prior to procedures to prevent bleeding in mild disease. So desmopressin decreases the degradation of von Willebrand's factor. So first line for hemophilia A is factor VIII. Second line, if mild disease and you want to prevent bleeding, you can give DDAVP because it increases the time that von Willebrand's factor is there. So hemophilia B. Hemophilia B is called Christmas disease as well. And Christmas disease, hemophilia B, is a factor IX deficiency. It's very similar to hemophilia A. It's X-linked recessive and occurring almost exclusively in males, again known as Christmas disease, and it's clinically indistinguishable from hemophilia A. It's a lack of factor IX, and it affects the clotting cascade, leading to a failure of hematoma formation. Clinical manifestations are hemarthrosis at 80%, delayed bleeding or swelling in weight-bearing joints, excessive hemorrhage in response to trauma or surgery. And again, hemophilia is less commonly present with purpura and petechiae because platelets typically cause these dysfunctions. And for diagnosis, a prolonged APTT again, this is the intrinsic pathway, a normal PT, that's the extrinsic pathway, that's the warfarin pathway. And for mixing studies, the PTT does correct with the mixing studies, indicating it is just a factor deficiency. And it's low factor IX, and this is the most sensitive test. You want to do factor IX infusion, it's the first line. And remember, desmopressin is not useful for hemophilia B. So it's used in mild diseases of hemophilia A, but it's not useful in hemophilia B. Next we'll go into von Willebrand's disease. So von Willebrand's disease is an autosomal dominant disorder associated with ineffective platelet adhesion due to deficient or defective von Willebrand's factor. It's the most common hereditary bleeding disorder. 1% of all population may be also acquired. So that's hereditary bleeding disorder, not a hypercoagulability disorder. Functions of von Willebrand factor is to promote platelet adhesion by cross-linking the GB2B receptor on the platelet with exposed collagen on damaged epithelium. So it just helps with that primary hemostasis. Von Willebrand's factor also prevents factor VIII degradation. So now that makes sense in that hemophilia A, why we're able to give second line DDAVP, because it increases the release of von Willebrand's factor, and von Willebrand's factor prevents the factor VIII degradation. So the whole point is to eventually get that factor VIII increased in the hemophilia A. So, which is why it's also important to know in von Willebrand's disease, the von Willebrand's factor prevents the factor VIII degradation. For clinical manifestations in von Willebrand's disease, we have mucocutaneous bleeding, epistaxis, bleeding gums, petechiae, purpura, bruising, menorrhagia, prolonged bleeding after minor cuts, and also incisional bleeding is less common in von Willebrand's disease than hemophilia, so it's more mild. Initial labs, coag studies, they'll have a prolonged PTT, even though it is typically in that primary hemostasis. However, it's a prolonged PTT because von Willebrand's factor increases the prolonging of factor VIII, so the lack of von Willebrand's factor, of course, they can't keep the factor VIII that long, so we're going to have a deficiency there. And PTT and bleeding time are prolonged worse with aspirin. So if this is given concordantly with aspirin, you're going to have a prolonged PTT and bleeding time much worse. And platelet count is usually normal, except in von Willebrand's 2B, which is associated with mild thrombocytopenia. So screening tests. Plasma von Willebrand's antigen will have a decreased von Willebrand's factor antigen or von Willebrand's factor activity, and a plasma activity of von Willebrand's factor will have ristocetin cofactor activity. So ristocetin cofactor activity. So it's just a different test for that plasma von Willebrand's factor. And von Willebrand's factor collagen binding. No platelet aggregation with ristocetin in von Willebrand's disease. Factor VIII activity may be decreased as well because of that faster degradation, because von Willebrand's factor typically keeps it up for longer, that factor 8. So again, screening tests, the plasma antigen will have decreased activity. The plasma activity will have a ristocetin cofactor activity. And of course, factor 8 may be decreased. And the gold standard is the ristocetin-induced platelet aggregation overall. So the ristocetin-induced platelet aggregation is the gold standard overall for von Willebrand's disease. For management overall of von Willebrand's disease, type 1 is quantitative deficiency. It's the most common type overall. And for mild to moderate bleeding, you can do DDAVP, which is desmopressin. If it's severe, you want to jump to something stronger. So that's the von Willebrand's factor-containing products. The factor 8 concentrates as well. For minor procedures, just do the desmopressin. For major procedures, you step up to a stronger agent, the von Willebrand's factor-containing products, or the also human-derived factor 8 concentrates as well. For type 2, this is a qualitative deficiency. You just want to use DDAVP. For type 3, it's very severe. You want to do the von Willebrand's factor-containing products, which are more strong. Next, we'll go to factor 5 Leiden mutation. Factor 5 Leiden is the most common inherited cause of hypercoagulability, thrombophilia, and it's 5% of the US population, factor 5 Leiden. It's a mutated factor 5, which is resistant to the breakdown by activated protein C, so leading to increased hypercoagulability. So typically protein C will stop the extra clotting. So protein C clotting stops the extra clotting, similar to the Adams TS13 in the TTP, which stops the extra action of von Willebrand's factor. Here it's the same mechanism, just to a clotting factor. So it's a mutated factor 5, which refuses to get broken down by the protein C. So that would typically stop the extra clotting again, and now we're having hypercoagulability because we have nothing to stop that extra clotting. So that's factor 5 Leiden mutation, in which there's an increased risk of DVT, PE, hepatic vein or cerebral vein thrombosis, also importantly an increased risk of miscarriages during pregnancy. However, it's not associated with increased risk of MI or CVA. For diagnosis, an activated protein C resistance assay. If it's positive, you want to confirm with DNA testing. DNA testing, you'll do that mutation analysis. It's used in patients with a family history of factor 5 Leiden or members of a thrombophilic family. They'll have a normal PT and PTT. For management, high risk needs indefinite anticoagulation. For moderate risk, one thrombotic event with a prothrombotic stimulus or asymptomatic prophylaxis during high-risk procedures. And you want to do low molecular weight heparin for pregnancy to prevent those miscarriages as well. Next, we'll go to protein C or protein S deficiency. So protein C, protein S stands for stopping clots. So like we said in the factor 5, similar. So stopping clots, S and C. So protein C and S are vitamin K dependent anticoagulant proteins produced by the liver that stimulate fibrinolysis in an inactivation of factors 5 and 8. Decreased protein C and S leads to hypercoagulability. So they also help to stop the extra clotting. So if we're having a problem with the protein C or S, we're going to have extra clotting. Etiologies can be inherited or acquired, and clinical manifestations are an increased incidence in DVT and PE. Also, warfarin-induced skin necrosis as well. Very important to know warfarin-induced skin necrosis with protein C or protein S deficiency. Also, purpura fulminans in the newborn, which is red purpuric lesions at pressure points, progressing to painful black eschars. So, most important to know, however, warfarin-induced skin necrosis and the increased risk of DVT and PE with protein C and S deficiency. So protein S and C stand for stopping clots. So without that, we're not going to be able to stop the formation of clots. Management is protein C concentrate and also indefinite anticoagulation. If they have warfarin-induced skin necrosis, you want to immediately discontinue warfarin, administer vitamin K and heparin, protein C concentrate, and FFP. For antithrombin 3 deficiency, this is a different disorder, decreased levels of antithrombin 3 leading to hypercoagulability. So typically antithrombin 3 inhibits the coagulation by neutralizing the activity of thrombin, factor 2A, 9A, and 10A, decreasing the levels which lead to increased risk of clotting. So again, it can be inherited or acquired, and of course, increased incidence of DVT and PE. You want to do antithrombin 3 assays, and for thrombosis, you want to do high-dose IV heparin, followed by oral anticoagulation therapy indefinitely. So antithrombin 3 deficiency. Next will be heparin-induced thrombocytopenia. For heparin-induced thrombocytopenia, this is an acquired thrombocytopenia, especially within the first 5 to 10 days of the initiation of heparin. So it's a precipitous drop within the first 5 to 10 days of the initiation of heparin for heparin-induced thrombocytopenia, or HIT. The risk factors are unfractionated, which is much more common than low molecular weight heparin, also surgical over medical, and female over male. For the pathophysiology, it's autoantibody formation to the hapten of heparin and a platelet factor 4 that causes platelet activation and consumption, leading to a simultaneous thrombocytopenia and thrombosis. And it's important to know some names of different heparins, like dalteparin or enoxaparin, because you might want to stop heparin, of course, so you want to switch from something else. So clinical manifestations, thrombocytopenia and thrombosis, venous thrombosis, gangrene, which could be severe. And for diagnosis, you want to know the 4 T's for heparin-induced thrombocytopenia. Thrombocytopenia, timing of the platelet drop, remember 5 to 10 days after the initiation of heparin, a precipitous drop, as well as thrombosis in the absence of other sequelae. Heparin-induced thrombocytopenia antibody testing can be done. And management is, of course, immediate discontinuation of all heparin and initiation of a non-heparin anticoagulant. Non-heparin anticoagulants would be agatroban and leperidan and agatroban for non-heparin anticoagulants. These are direct thrombin inhibitors. You can also do fondaparinux and also direct oral anticoagulants like apixaban, edoxaban, rivaroxaban, and dabigatran. Long-term anticoag with warfarin can only be started after other non-heparin anticoagulation has been started and the thrombosis has decreased because of the initial prothrombotic state normally associated with the first 5 days of the initiation of warfarin. So you don't want to start warfarin right away after you've discontinued that heparin in heparin-induced thrombocytopenia. So next we'll go to aplastic anemia. So for aplastic anemia, this is a pancytopenia with bone marrow hypocellularity. The pathophysiology is T cells attacking the hematopoietic stem cells, autoimmunity, or direct stem cell damage leading to bone marrow failure, including replacement of bone marrow with fat. Idiopathic is the most common cause. It could be also radiation. And very important to know, it could be seronegative viral hepatitis, but most importantly is parvovirus B19 causing the aplastic anemia. Also other patients with baseline hemolytic anemias like sickle cell, G6PD. Meds, importantly, can cause aplastic anemia. Chloramphenicol, which remember, chloramphenicol also causes the gray baby syndrome, and also sulfa drugs. Chemotherapy, anticipated effects, anti-epileptics like carbamazepine, phenytoin, quinidine, NSAIDs, antithyroid meds too. B12 and folate deficiency can cause pancytopenia as well. Symptoms of pancytopenia will be easy bruising, bleeding, frequent infections, and fatigue. And note that it's all of those because it's all cell lines that are being destroyed in this aplastic anemia. Mucocutaneous bleeding, the anemia will lead to weakness and fatigue, and the leukopenia will lead to recurrent or frequent infections and fever. For diagnosis, CBC with peripheral smear, at least 2 cytopenias must be had for it to be considered an aplastic anemia. So lack of reticulocytes, a thrombocytopenia, a neutropenia, anemia as well, nucleated red blood cells if the marrow fibrosis is present as well. And for bone marrow biopsy, that's of course the most accurate test, in which you'll see a hypocellular, fatty bone marrow, which will be fat cells and fibrotic stroma replacing the normal marrow. So we'll see a lot of bone marrow changes. And typically it's a diagnosis of exclusion in the setting of bone marrow failure. For management, supportive management is the initial treatment of choice. Infection prophylaxis with broad-spectrum antibiotics because of that neutropenia. You can do packed red blood cell transfusions with a hemoglobin under 7, or you can do platelets as well. Severe aplastic anemia and otherwise healthy, you want to do an allogeneic hematopoietic stem cell transplantation as the treatment of choice. So that's severe aplastic anemia in an otherwise healthy patient under 50 is an allogeneic hematopoietic stem cell transplantation as the treatment of choice. And immunosuppressive therapy in patients over 50 years of age or in patients without a matched donor. So it matters about the age. If they're under 50, you want to do that hematopoietic stem cell transplant. If they're over 50, they can't do it. You have to do the immunosuppressive therapy, again, if they're over 50. So next will be hereditary hemochromatosis. So hemochromatosis is an autosomal recessive disorder characterized by excess iron deposition in the parenchymal cells of the heart, liver, pancreas, and endocrine organs. So remember, in the heart, it causes the restrictive cardiomyopathy, important to know, and of course liver, pancreas, and endocrine organs as well. It's associated with the C28-2Y HFE genotype, increase in Northern Europeans. Pathophys is a mutation in the HFE protein, which leads to a decreased hepcidin, the iron regulatory hormone. So decreased hepcidin leads to the increased intestinal iron absorption, leading to organ dysfunction from iron deposition in the parenchymal cells. So it's basically just uncontrolled absorption of iron, where typically we control it much better and don't absorb all the iron that comes through the diet. There's many manifestations, and they can occur in stages. So symptoms don't usually occur until after 40 years of age. In the liver, they may have cirrhosis, hepatomegaly over time. For endocrine, they could have diabetes from the infiltration of the pancreatic beta cells and hypothyroidism as well. For the heart, restrictive or dilated cardiomyopathy, but typically restrictive. Also arrhythmias, heart block. For reproductive, they could have hypogonadism, erectile dysfunction or atrophy. For joints, arthralgias, arthritis. For skin, metallic or bronze skin. This is also known as the bronze diabetes. And we also saw the bronze diabetes in Addison's, where it's that hyperpigmentation as well. Increased susceptibility to bacteria that feed on iron, Yersinia enterocolitica and Vibrio vulniferus. So again, that's that bacteria that feed on iron. That's why in the anemia of chronic disease, we see that sequestration of iron and the ferritin as an acute phase reactant, so decreasing the iron that's in the blood in that anemia of chronic disease. So the bacteria feed on the iron. Diagnosis, iron studies is the initial test of choice. An increased serum iron, ferritin, and transferrin saturation. Normal or decreased TIBC, of course, because we don't want any more. And they may have abnormal LFTs. You can do genetic testing or an abdominal MRI. And liver biopsy is the most accurate test, in which you'll see increased hemosiderin, which is the storage iron, in the liver parenchyma with Prussian blue staining. For management, phlebotomy is the mainstay of treatment. It may be performed weekly until ferritin decreases 50 micrograms, decrease in transferrin saturation, or until mild anemia occurs. May need maintenance phlebotomy therapy. So we're waiting till a mild anemia occurs, so that if we have a mild anemia, the body is going to want more iron, and we have plenty of iron to go around, so it will easily suck up more of that iron to make those red blood cells. So inducing a mild anemia is good in this phlebotomy treatment for hemochromatosis. And secondarily, you can do iron chelating agents, and this is in patients who are unable to undergo phlebotomy. It's more effective in patients with erythropoietic hemochromatosis, and of course, deferoxamine is the treatment for this. But typically, first line is phlebotomy, scheduled phlebotomy for hemochromatosis. So next we'll go over some cancers, so multiple myeloma. Multiple myeloma is called plasmacytoma as well. So this is cancer associated with proliferative single clonal plasma cells, leading to an increased production of ineffective monoclonal antibodies especially IgG and IgA and IgM. Most common primary bone malignancy in adults. Risk factors are over 65, African Americans, men, and pathophys is plasma cells that accumulate in the bone marrow, interrupting the bone marrow's normal cell production. Protein accumulation also causes kidney injury. So how we can remember the symptoms are a couple of ways. So some people remember it as CRAB, C-R-A-B, where it's calcium, renal, anemia, and bone. Or it could be break, B-R-E-A-K, where it's bone pain, which is the most common symptom, and vertebral involvement, which I got a question on. Vertebral involvement is the most common, also the ribs, and osteolytic lesions. So that's the bone pain with the vertebral involvement and the osteolytic lesions. They'll have R, recurrent infections due to the leukopenia and ineffective Ig production, and also hyperviscosity. They'll have E, elevated calcium due to the osteoclast activation from the plasma cells leading to bone destruction. They'll have anemia, which will lead to that fatigue, pallor, weakness, weight loss, and of course K, kidney injury, due to the light chain protein antibody deposition of the kidneys. So don't forget that kidney injury in multiple myeloma, as well as the vertebral fractures in multiple myeloma with osteolytic lesions. For diagnosis of multiple myeloma will be a serum protein electrophoresis, in which you'll see the classic monoclonal protein spike. IgG is most common. Urine protein electrophoresis can also be done, in which you'll see Bence-Jones proteins composed of kappa or lambda light chains. On CBC, you'll see the rouleau formation, which we talked about, which is that classic stacking of coins appearance due to the increased plasma protein, increasing the ESR, so it sinks to the bottom faster because they're stacked. Skull radiographs, the punched out lytic lesions, and bone scans are not helpful for these patients. Bone marrow aspiration, we can see plasmacytosis, which is the definitive diagnosis. So we want to do that bone marrow aspiration, with which we'll see the plasmacytes, the plasmacytosis, over 10%. That's definitive. And the management is autologous stem cell transplantation as the most effective treatment. It may be preceded by induction chemo as well. And chemo usually controls the symptoms temporarily. However, autologous stem cell transplantation is the most effective therapy. So there's many pathognomonic things here for multiple myeloma. Just to quickly go through them. It's composed of plasma cells, IgG, most common primary bone malignancy in adults, elderly over 65. You can think about it as break, B-R-E-A-K, bone pain, which is that vertebral fractures or osteolytic lesions, recurrent infections, elevated calcium due to the clasts, anemia, and of course kidney disease due to the deposition of those light chains. For diagnosis, best thing is serum protein electrophoresis, in which you'll see the IgG monoclonal protein spikes, IgG monoclonal protein spikes, and for the urine protein electrophoresis, that's the Bence-Jones proteins with kappa or lambda light chains. CBC rouleau formation, which is the stack of coins with the increased ESR. Radiographs, the punched out lytic lesions of the skull, and a bone marrow aspiration is definitive, and you'll see a plasmacytosis over 10%, and management is an autologous stem cell transplant. Okay, so next will be secondary erythrocytosis. So erythrocytosis is a major cause of increased red blood cell mass. It's most common in obese and also history of cigarette smoking. So a secondary erythrocytosis is an increase in hematocrit as a response to another process. So typically it's reactive and physiologic. This is due to hypoxia long-term, especially in pulmonary diseases, COPD. High altitude over time leads to that secondary erythrocytosis. Also tobacco smokers overall just chronically giving them hypoxia, and cyanotic heart disease. Reactive is the most common type, so it's secondary to something else. It could be pathologic with no underlying tissue hypoxia, which should be like renal disease, like a renal cell carcinoma. Or it could be a relative polycythemia, normal red blood cell mass in the setting of a decreased plasma volume. So you're basically losing free water, and it looks like they're having a polycythemia or an erythrocytosis, and that's dehydration. Clinical symptoms are related to the precipitating cause, like the COPD or the renal disease. Physical exam will see hypoxic signs like cyanosis, clubbing, hypertension.
For diagnosis of secondary erythrocytosis, increased RBCs and hematocrit with normal white blood cells and platelets, normal erythropoietin levels, as the red blood cell mass is normal in reactive polycythemia due to a decrease in plasma volume, and the management, of course, treat the underlying disorder, such as smoking cessation, COPD management, renal disease management.
So next we'll go into polycythemia vera. This is a primary erythrocytosis. It's an acquired myeloproliferative disorder with autonomous bone marrow overproduction in all three myeloid stem cell lines, primarily the increased RBCs, but associated with increased granulocytic white blood cells and platelets. So remember the myelo side and the myeloid line as well as the lymphoid line. So the lymphoid line, how I remember it, is BLT. The lymphoid is the L, and it has T cells and B cells. On the other side, we have all the granulocytes in the myeloid line. So like the neutrophils, the monocytes, the lymphocytes, etc. Not all of those are granulocytes, however, that's how I remember it for the myeloid stem cell line. So the myeloid stem cell line is primarily the RBCs, but it's associated with the increased granulocytic white blood cells and platelets. And for polycythemia vera, and not to get it confused with any of the leukemias, this is an overproduction of all three myeloid stem cell lines. The pathophys is a JAK2 mutation, which leads to that primary erythrocytosis, increase in the hematocrit, and in the absence of hypoxia. Risk factors are 50-60 years of age and more common in men, 60%. Manifestations are due to increased red blood cell mass, hyperviscosity, and thrombosis. For the hyperviscosity, they'll typically have headache, dizziness, tinnitus, blurred vision, weakness, fatigue, pruritus, especially after a hot bath or shower, so that's very important. That's due to that histamine release from the basophils. So remember, basophils in that myeloid stem cell line, pruritus, especially after a hot bath or shower. So for polycythemia vera, we'll also have thrombosis, and also in physical exam, hepatosplenomegaly, also facial plethora, a flushed face, engorged retinal veins as well. So we can also see facial plethora in mitral stenosis, interestingly as well. So hepatosplenomegaly, facial plethora. For diagnosis, you need all three major, or the first two major plus one minor criteria. So the major criteria for polycythemia vera are an increased red blood cell mass. That's an increased hemoglobin, increased hematocrit, over 54% in men, or over 51% in women. Also in bone marrow biopsy, you'll need to see hypercellularity, erythroid, granulocytic, or megakaryocytic proliferation, and a JAK2 mutation present. So those are the three major. A JAK2 mutation is present, a hypercellularity in at least three myeloid stem cell lines, and an increased red blood cell mass. So that's that hemoglobin, hematocrit, over 54% in men, 51% in women. And for the minor criteria, decreased serum erythropoietin levels, normal O2 saturation, increased leukocyte alk phos, increased granulocytic white blood cells, platelets, B12, iron deficiency despite polycythemia. Management, low risk. Phlebotomy is the first line until the hematocrit's under 45%. Low dose aspirin to prevent thrombosis. So phlebotomy and aspirin for low risk. High risk, if they're over 60 and they've had some thrombosis, you want to do all the above plus hydroxyurea, which is decreased red cell count. Interferon alpha is second line, and ruxolitinib, a JAK inhibitor, if no response to hydroxyurea. And symptomatic, antihistamine for pruritus, allopurinol for the hyperuricemia, if they're lysing those red blood cells. So for exam tip, primary versus secondary erythrocytosis. For primary, again, that's the polycythemia vera, you'll have the normal O2 saturation, however decreased erythropoietin, of course, because you already have enough red blood cells, increased white blood cells and platelets because it's those three stem lines of the myeloid. For secondary erythrocytosis, which would be hypoxemic, they'll have a decreased O2 saturation increased erythropoietin, as it's typically reactive as the most common cause, and normal white blood cells and platelets because it's only that one thing, just the erythrocytes. So next we'll go to myelodysplastic syndrome. Myelodysplastic syndrome is a heterogeneous pre-leukemic disorder characterized by abnormal differentiation of cells of the myeloid cell line, hypercellular bone marrow, resulting in ineffective hematopoiesis in the bone marrow, pancytopenia. It's over 65 years of age, radiation therapy, chemotherapy, benzene exposure as well. For symptoms of the pancytopenia, they'll have easy bruising, bleeding, frequent infections, of course, and fatigue. CBC is diagnostic with decreased number of one or more myeloid cell lines. Platelets, neutrophils, or red blood cells may be nucleated, and again, that's the myeloid cell lines, not the lymphoid. Hyposegmented neutrophils, normocytic or macrocytic anemia, and on bone marrow biopsy, normal or hypercellular. 20% are associated with hypocellularity, so neither are really diagnostic. Dysplastic bone marrow is the hallmark, however. So dysplastic bone marrow, it's in the name myelodysplastic syndrome. Increased myeloblasts, but under 20%. Also ringed sideroblasts and pseudo-Pelger-Hewitt cells. These are hyposegmented and hypogranulated neutrophils. So that's important that it's increased myeloblasts on bone marrow biopsy, but it's under 20%. And those are dysplastic bone marrow cells. So under 20%. The goals are symptomatic improvement to improve survival and to decrease the progression to acute myelogenous leukemia, AML, with their hour rod spots. Supportive management. Not all patients require treatment, but some may need intermittent blood or platelet transfusions. Systemic pyrimidine analogs can be used, and allogeneic stem cell transplantation is the only effective cure, but difficult in patients over 50 years of age. So next we'll go into the different leukemias. So the first one, ALL, acute lymphocytic leukemia. And before we'll do that, we'll review the blood stem cell lines. So there's two blood stem cell lines. There's the myeloid and the lymphoid line. The lymphoid line is, how I remember it, is it's the beta cells, the T cells, and the natural killer cells. And this is the lymphoid cell line. It's BLT, beta cells, lymphoid cell line, and T cells. On the other side is the myeloid cell line. This is the red blood cells, the platelets, as well as the granulocytes, which are like eosinophils, basophils, neutrophils as well. So that's all in the myeloid stem cell line. So acute lymphocytic leukemia. So acute lymphocytic, so this is the lymphoid cell line, and these are B cell, which is most common. It could also be T cell, and it's malignancy arising from immature lymphoid stem cells in the bone marrow. It's importantly the most common childhood malignancy at 25%, and it peaks at ages 2 to 5 years old, boys more common than girls, and Down syndrome is also a risk. The pathophys is very important to know. It's an overpopulation of immature white blood cells, blasts that overtake normal hematopoiesis, resulting in pancytopenia. So pancytopenia, fever and infections, leukopenia, bleeding from thrombocytopenia like petechiae, purpura, anemia, pallor, and fatigue. CNS symptoms, headache, stiff neck, visual changes, vomiting, Mets most common to the CNS. Physical exam, hepatomegaly or splenomegaly is most common, also lymphadenopathy. For diagnosis, very important, CBC with peripheral smear, white blood cells of 5,000 to 100,000. So typical is 5,000 to 11,000. Anemia and thrombocytopenia. On bone marrow aspiration, we have hypercellularity with over 20% blasts, and this is definitive diagnosis. And that's the over 20% from the lymphoid cell line, whereas in the myelodysplastic syndrome, we just did that, and that's myeloblast, so that's in the myeloid stem cell line, and that was under 20%. However, it still was dysplastic, but it was under 20%. This is over 20%, and it's in the opposite cell line. It's in the lymphoid cell line because it's acute lymphocytic leukemia. You can also do flow cytometry. However, the bone marrow aspiration is the definitive diagnosis. And luckily, it's highly responsive to a combination of chemotherapies. Remission is over 85%. And you can use a number of different ones: anthracyclines, vincristine, corticosteroids. Maintenance therapy includes 6-mercaptopurine and methotrexate. Imatinib used if Philadelphia chromosome is positive. But CNS disease and CNS prevention, you need to use intrathecal methotrexate. So just to run through some of the most important things about ALL. Most common childhood malignancy, pancytopenia, hepatomegaly, splenomegaly, lymphadenopathy, over 20% blasts of the lymphoid cell line, which are your B cells or your T cells. That's that hypercellularity. The bone marrow biopsy is the best test. And remember, the most common mets are to the CNS. So it's very important to know that it's highly responsive to combination chemo with a remission over 85% for ALL. And CNS disease or CNS preventative, you need to know intrathecal methotrexate. So intrathecal methotrexate for CNS disease or CNS prophylaxis. Next we'll go to tumor lysis syndrome. Tumor lysis syndrome is an oncologic emergency occurring with treatment of the neoplastic disorders due to rapid tumor cell lysis after initiation of chemotherapy, releasing massive amounts of potassium, phosphate, and nucleic acids into the circulation, also uric acid too. High tumor burden would be a risk factor, initial white blood cells over 20,000, dehydration, and a volume depletion. Or if they're in a large proliferative rate, like in ALL, or in high-grade lymphomas, like Burkitt's lymphoma. Clinical manifestations are related to the metabolic derangements, including muscle cramps, tetany, nausea, vomiting, lethargy, heart failure, kidney injury, and arrhythmias. So these are all due to the lab findings like hyperphosphatemia, hypocalcemia, hyperuricemia, hyperkalemia, and AKI, including the uric acid nephropathy. So especially that buildup of everything that's inside of a cell is getting released with the tumor lysis syndrome. So lots of potassium, lots of uric acid, lots of phosphate, and you're decreasing the calcium as well. Management, treat the electrolyte abnormalities and IV fluids. So you want to promote the excretion, you want to dilute it, and very important for prophylaxis of tumor lysis syndrome, if you anticipate this after some chemotherapy, for instance, is respirocase, or allopurinol, plus aggressive IV fluid hydration. And you can also do hemodialysis if severe. So respirocase is a recombinant uricase that catalyzes oxidation of uric acid to a stable compound allantoin. So it may be more effective than allopurinol, and it's contraindicated in G6PD deficiency. So remember, respirocase was like a second-line agent in the treatment of gout as well. And that's the long-term treatment of gout. But respirocase here is a prophylactic agent, first line, plus the IV fluid rehydration as well for tumor lysis syndrome. So next we'll go into CLL, chronic lymphocytic leukemia, and this is B cell lymphoid. So mature B cell clonal malignancy. Most common form of leukemia in adults, and it's important to know it's of increased age, so over 70 years old. So very important. So if it's lymphocytic, it's either very young or very old. CLL is very old, ALL is very young. If you have an M in the middle, that's middle-aged. So AML is middle-aged and CML is middle-aged. So this one right now, CLL, is very old patients, typically 70 years or older. Clinical manifestations, usually asymptomatic. It's typically an incidental finding of lymphocytosis. For pancytopenia, you'll also see anemia symptoms like fatigue, etc. They have typical B symptoms of lymphoma. And they'll have lymphadenopathy, most common physical exam finding. It could be supraclavicular or generalized. The lymph nodes are usually firm, round, non-tender, and freely mobile. Splenomegaly is the most common finding as well. So lymphadenopathy actually is the most common finding, and splenomegaly is the second most common finding. And it's usually painless and non-tender to palpation. For diagnosis, you'll see an absolute lymphocytosis, over 5,000. Small, well-differentiated, normal appearing lymphocytes with scattered smudge cells. Smudge cells are just lab artifact when the fragile B cells become crushed by the slip cover during slide preparation. So it's easy to remember CLL, crushed little lymphocytes. So it's a lymphocytosis, so crushed little lymphocytes, CLL, and they're crushed, so they're smudged, and this is due to that lab artifact. So that's how we can remember CLL with the smudge cells, the lymphocytosis, and how they're all broken up and smashed over that. So again, it's over 5,000 is an absolute lymphocytosis, because lymphocytes are typically a smaller percentage of the overall white blood cells. So having over 5,000 is quite a bit. We'll also have a hypogammaglobulinemia, and immunophenotypic analysis can be done as well, and that's flow cytometry. So typically this is something they die with and not from. So it's very indolent, it's asymptomatic in stages 1 and 2, so you just observe it, especially at this age, and also radiation can be done, however, sometimes observing it. Symptomatic, progressive, stage 3 or 4, you can do fludarabine or rituximab, or cyclophosphamide or chlorambucil, but the bolded one is fludarabine. So fludarabine for CLL, fludarabine. So next we'll go into AML, acute myeloid leukemia. So AML, acute myeloid leukemia. M is in the middle, so it's middle-aged patients, acute myeloid leukemia. It's a group of hematopoietic neoplasms characterized by clonal proliferation of the myeloid precursors with decreased ability to differentiate into mature cells. So they can't differentiate into mature cells, and it's acute and not chronic, so therefore it's higher up, closer to the origination of the stem cells. So they have a decreased ability to proliferate into the mature cells. It's most common acute leukemia in adults, 80% of cases, and the mean onset is 65 years of age. The pathophys is accumulation of leukemic blasts, immature white blood cells, in the bone marrow, peripheral blood, or occasional other tissues. Increased production leads to a pancytopenia. There's 3 major subtypes: acute promyelocytic leukemia, APL or M3 variant, which is associated with DIC, and also the presence of Auer rods. And those Auer rods, I'll have a picture, and that's the pink needle-shaped things stabbing out of the cytoplasm, basically, of the cells. So those are the Auer rods, which are pathognomonic for the AML. And also myeloperoxidase positivity. So in the APL, the acute promyelocytic leukemia, you have the myeloperoxidase positivity, a risk of DIC, and the presence of Auer rods. So DIC, Auer rods, and myeloperoxidase positivity in the APL. And for acute monocytic leukemia, it's associated with infiltration of the gums, so you might see some gingival hyperplasia. For clinical manifestations, a pancytopenia anemia, so general fatigue is the most common presenting symptom, as opposed to CLL, which lymphadenopathy was the most common, and second most common was splenomegaly. For AML over here, pancytopenia, fatigue is the most common presenting symptom. They may have some thrombocytopenia, mucocutaneous bleeding, and neutropenia. And on diagnosis, you can do CBC with peripheral smears, the best initial test, normocytic, normochromic, thrombocytopenia, may have circulating myeloblasts, of course, as it's a myeloid leukemia. So circulating myeloblasts on CBC with peripheral smear. And bone marrow biopsy is the gold standard, over 20% myeloblasts. So we saw the under 20% myeloblasts in an acute myelodysplastic disorder, and this is now over 20% myeloblasts, which is in concordance with AML, acute myelogenous leukemia. So also Auer rods, like we said, that pink-red rod-shaped like granular structure poking out of the cytoplasm, and that's with the acute promyelocytic leukemia, the APL. If we do immunophenotyping, we'll have the myeloperoxidase positivity in the APL, again, very important. And for management, combination chemo. All trans-retinoic acid can be added to the M3 variant, promyelocytic leukemia, the APL, vitamin A. So APL can get vitamin A as well. So we'll just run through it one more time. AML, so most common leukemia in adults, accumulation of leukemic blasts, immature white blood cells, and those are over 20% myeloblasts. You want to do CBC first, then bone marrow biopsy, and you'll see the Auer rods. You'll have myeloperoxidase positivity and DIC. if you have the most common subtype, which is the APL, the acute promyelocytic leukemia, or the M3 variant. And of course, also know the risk of gingival hyperplasia as well. And you want to treat, or you want to add vitamin A, which is the transretinoic acid, to the M3 APL type as well. So now we'll go over leukostasis reaction. So leukostasis. This is a symptomatic hyperleukocytosis commonly seen in acute myelogenous leukemia or chronic myeloid leukemia in a blast crisis. So leukostasis. So medical emergency due to the decreased tissue perfusion from leukostasis. So they're basically just clumped up inside of the bone marrow and they're having stasis. So white blood cells that are clumped up and not moving inside the bone marrow. The pathophys is leukostasis due to increased blood viscosity and white blood cell plugs in the microvasculature, impeding blood flow in addition to causing local hypoxemia due to the high metabolic activity and rapidly dividing blasts. So this is very bad. Clinical manifestations, pulmonary, neurologic, others could be priapism, bowel infarction, MI. Diagnosis, hyperleukocytosis, typically white blood cells over 100,000. And remember, normal is about 5 to 11. And symptoms due to tissue hypoxia, like lungs, CNS. So that's that hyperleukocytosis, and this is a medical emergency. So we need to do pretty immediate cytoreduction. This is a leukapheresis, which is first line because it's associated with rapid improvement. Then we can do chemo, hydroxyurea, or induction chemo. And also we want to prophylax for tumor lysis syndrome for that leukostasis reaction. So now we'll move further to chronic myelogenous leukemia, CML. And again, M is in the middle of the name, so it's typically middle-aged. And there's a few pathognomonic things for this one. Myeloproliferative disorder of uncontrolled production of mature and maturing granulocytes. So again, this is in the myeloid stem line. So we're having all those granulocytes, basophils, eosinophils, but mostly neutrophils with fairly normal distribution. So again, uncontrolled production of mature and maturing granulocytes from the myeloid stem cell line, predominantly neutrophils, but there's also some basophils and eosinophils. Pathophys is the fusion of two genes, BCR on 22 and ABL1 on 9, resulting in a BCR-ABL fusion gene. This is a translocation between chromosome 9 and 22, which is the classic Philadelphia chromosome, the abnormal chromosome 22, which harbors the BRCA-ALB1 gene. So how can we remember this? Is CML, country music lover, somebody said, is in Philadelphia on 9/22. So CML, country music lover, in Philadelphia on 9/22. So 9/22 are the two genes in Philadelphia chromosome, CML, country music lover. Splenomegaly is the most common finding, 75%. Pruritus after hot baths and showers from the histamine release. So we also saw that in polycythemia as well. So important to differentiate. Chronic phase, accelerated, and blast crisis are important to know. And in that blast crisis presents as an acute leukemia with extramedullary tissue involvement, especially the lymph nodes, skin, and soft tissues. So it goes chronic phase, accelerated, and then blast crisis with the acute leukemia. For diagnosis, CBC with peripheral smear, you'll have the leukocytosis, and it may be strikingly elevated with granulocytic cells like neutrophilia especially, and we also said it could be accompanied by basophilia and eosinophilia. The cells look normal but are abnormal on immunochemistry. So it's chronic, so it's deeper down the cell line as opposed to blasts, which are in an acute myelogenous leukemia. So that's why we see the basophilia and neutrophilia and eosinophilia in this, because those are some of the last steps down the cell line, down the myeloid cell line of those granulocytic cells. So that's for chronic, that's how we know that it's going to be neutrophilia, basophilia, or eosinophilia when it's in the chronic phase. So also leukocyte alk-phos score will be decreased, and bone marrow biopsy will see granulocytic hyperplasia. And again, acute blast crisis is over 20% blasts. For management, we'll see the Philadelphia chromosome positive, then we'll use the tyrosine kinase inhibitor first line, imatinib. So this drug is unique to this disease, CML. It's one of the first chemo drugs that actually worked for a cancer here. So tyrosine kinase inhibitors are first line, inhibiting that tyrosine kinase, and that's imatinib. They inhibit the Philadelphia chromosome, tyrosine kinase activity, and myeloid leukemic cell proliferation. So the whole problem is the tyrosine kinase overproduction or overexpression. So imatinib is the drug for that. So it's important to know imatinib for CML. And again, country music lover, CML in Philadelphia, Philadelphia chromosome, 922, translocation between those two chromosomes, 9 and 22. So now we'll go to Hodgkin's lymphoma and then non-Hodgkin's lymphoma. So for Hodgkin's lymphoma, this has Reed-Sternberg cells, and non-Hodgkin's lymphoma does not. So that's the main differentiator that we need to know. For Hodgkin's lymphoma, it's a germinal or pre-germinal B-cell malignancy, so that's in that lymph side of the stem cell, originated in lymphatic system, of course. Bimodal, peaks at 20 and again at 50. Risk factors are EBV, Epstein-Barr virus, also immunosuppression and smoking. So better prognosis only due to its contiguous spread, not all over like the body in non-Hodgkin's lymphoma. So Hodgkin's lymphoma typically spreads contiguously, so it has actually a better prognosis. There's four main types. The most important to know is nodular sclerosing, which is the most common overall type, and it has a female predominance. The lymphocytic or lymphocytic rich in predominant type is the best prognosis, but nodular sclerosing is the most common type, and it's more common in females. For clinical manifestation of Hodgkin's lymphoma, you'll have asymptomatic, painless lymphadenopathy, which is the most common presentation. It's usually painless, but after alcohol ingestion, interestingly, it induces lymph node pain within minutes. So that's the only time it's painful, if they ingest alcohol and they have the painful lymph nodes in Hodgkin's lymphoma. They could have some upper body lymph nodes. The neck is the most common site, so they'll have the classic Virchow's node, the supraclavicular lymph nodes, and also cervical lymph nodes as well. Mediastinal lymphadenopathy or pain, second most common presentation, could be an incidental finding on chest radiograph, and the mass may be large without producing local symptoms. They could have fatigue, pruritus, intra-abdominal disease, hepatomegaly, splenomegaly. So they can also have those classic systemic B symptoms. B symptoms are fever over 100.4, night sweats, and weight loss, which is over 10% of body weight over 6 months. So again, B symptoms, night sweats, weight loss, and fever. Pell-Epstein fever is the cyclical fever that recurs at variable intervals of several days or weeks and lasts 1 to 2 weeks before waning. Symptoms are due to a cytokine release by the Reed-Sternberg cells. B symptoms indicate advanced disease. For diagnosis, excisional whole lymph node biopsy, and of course we'll see the Reed-Sternberg cell, which is pathognomonic. That's that classic owl eye appearance. For management, in early stages of the disease, 1 and 2, we can do chemo and radiation. Chemo alone is acceptable as well. Advanced, stage 3 or 4, combo chemo is the mainstay, and we have to know it's that ABVD. So almost ABCD, ABVD is for Hodgkin's lymphoma. That's adriamycin, which is doxorubicin, bleomycin, vinblastine, and dacarbazine. So that's that ABVD, adriamycin, bleomycin, vinblastine, and dacarbazine. And also refractory, you can do autologous hematopoietic transplantation and high-dose chemo. So one more time, just to run through Hodgkin's lymphoma, the most important things. Hodgkin's lymphoma is a B-cell malignancy originating from the lymphatic system. Bimodal, peaks at 20 and again at over 50. Risk factors EBV. Nodular sclerosing is the most common type, more common in females. You could have asymptomatic, painless lymphadenopathy. Alcohol ingestion increases the lymph node pain. That wasn't there. Classically supraclavicular or cervical nodes. Mediastinal masses, hepatomegaly, splenomegaly. B symptoms with the Pell-Epstein fever. Cyclical fever is that Pell-Epstein fever. And the B symptoms are fever, night sweats, and weight loss. So night sweats, weight loss, and fever. And B symptoms indicate advanced disease. You want to see, of course, the Reed-Sternberg cells, which are pathognomonic. That's the owl eye appearance. And then in advanced disease, you do the ABVD, adriamycin, bleomycin, vinblastine, and dacarbazine as treatment. So then we'll go into non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma is a little bit different. It's a heterogeneous group of lymphocyte neoplasms with proliferation in the lymph nodes and spleen. There's many different types. Two of the most common are diffuse large B cell. So diffuse large B cell is the most common type of non-Hodgkin's lymphoma. It's fast-growing and aggressive. It rapidly enlarges the lymph nodes of the neck, abdomen, and groin. It's most common in middle age and elderly. Average age is 70, and extranodal is seen in 40%. So these typically move around the body and have distant mets, unlike Hodgkin's lymphoma, which is typically contiguous spread. So NHL moves all over. There's also follicular, which is the second most common. Follicular is usually indolent and slow growing, but hard to cure. There's marginal zone. Marginal zone typically has three subtypes: extranodal, MALT, as well as H. pylori association. So that's important. The H. pylori association, I just got a question on that. H. pylori associated with the marginal zone lymphomas. So extranodal manifestations of the marginal zone non-Hodgkin's lymphoma, mucosal associated lymphoid tissue, MALT, is H. pylori infection associated. And then Burkitt's lymphoma. Burkitt's lymphoma is important to know. Intermediate sized B cell proliferation, CD20+, associated with EBV, associated with Epstein-Barr virus, and also pediatric, adolescent, and HIV patients. It's endemic to Africa, and it involves the jaw and facial bones, especially with malaria. And there's also sporadic types like GI and para-aortic involvement. So very important to know GI involvement as the most common site of extranodal involvement, especially with Burkitt's lymphoma. And also the immunodeficient type seen in HIV and immunosuppressants. And classically you have that biopsy with the starry night appearance. And Burkitt's is very aggressive. So some person said a mnemonic for remembering it is Burkitt's is somebody with a kite in the open ocean and on a starry night looking up, and they have the starry night on biopsy. Jaws is in the ocean, so it's involving the jaw off the east coast of Africa, which is where shark attacks are more common. So you know it's endemic to Africa. It involves the jaw, immunodeficient state associated with EBV, Epstein-Barr, non-Hodgkin's lymphoma, Epstein-Barr virus, and a starry night appearance as well. So risk factors are increased age, immunosuppression, importantly HIV, HCV, infections like EBV, HIV, H. pylori, very important. H. pylori is associated with gastric lymphoma. Autoimmune disorders as well. In clinical manifestations, painless lymphadenopathy and extranodal involvement. Extranodal involvement is common, more common than Hodgkin's lymphoma. Extranodal involvement is helpful to define the non-Hodgkin's lymphoma, and the GI tract is the most common site for extranodal involvement. Skin is the second most common. CNS is also common too. So that's non-Hodgkin's lymphoma. They could have the systemic B symptoms, fever, night sweats, and weight loss, but it's rarer in non-Hodgkin's lymphoma, but may be seen if it's advanced. So the B symptoms are more classic for Hodgkin's, and non-Hodgkin's is more classic for not having B symptoms. And remember, no Reed-Sternberg cells in non-Hodgkin's lymphoma. So the mnemonic for how you treat the intermediate, high-grade, or aggressive non-Hodgkin's lymphoma is RCHOP: rituximab, cyclophosphamide, hydrochloride, oncovorin, which is vincristine, and prednisolone. So RCHOP again: rituximab, cyclophosphamide, hydrochloride, oncovorin, and prednisolone. So RCHOP is for non-Hodgkin's lymphoma. So you can remember that because non-Hodgkin's lymphoma is a longer word than Hodgkin's, and that's a longer mnemonic. So RCHOP, as opposed to ABVD, which is Hodgkin's lymphoma. And lastly, we'll go into some chemotherapeutic drugs, as well as their side effects. So just generally, we'll go into some of these side effects. General chemotoxicities. For GI, they'll have nausea and vomiting with doxorubicin, cyclophosphamide, methotrexate, cisplatin, mucositis with 5-fluorouracil and methotrexate. Cardiovascular is important to know for the anthracyclines, The anthracyclines are doxorubicin and daunorubicin, and of course this is part of our ABCD2 squared mnemonic, which is in dilated cardiomyopathy. Pulmonary, bleomycin is very important to know for pulmonary, bleomycin, and also methotrexate. For neurologic, vincristine, methotrexate, and cisplatin. So remember, in ALL, we have to prophylax the CNS with methotrexate. Renal, high-dose methotrexate, cisplatin, cyclophosphamide as well. So lastly, we'll go over some tumor markers. So alpha-fetoprotein is associated with hepatocellular carcinoma, non-semitomatous germ cell testicular cancer, and also it's decreased in Down syndrome. For beta-HCG, again, non-semitomatous germ cell testicular cancer, choriocarcinoma, teratomas, and also trophoblastic tumors, of course, like the hydatidiform molar pregnancy, CA125, ovarian cancer, CA19-9, pancreatic cancer. It could also be GI, colorectal, esophageal, hepatocellular too for 19-9, but most predominantly pancreatic cancer. Calcitonin, medullary thyroid cancer, CEA, colorectal cancer, and PSA, prostate-specific antigen, prostate cancer. Can also be elevated in BPH and prostatitis as well. So that will conclude the hematologic and oncologic systems for Pance preparation.